And it's my privilege and honor to introduce Dr. Mauza Al-Salami, who's the first speaker. Dr. Mauza has an advanced diploma and fellowship in fetal medicine from London, and he's a senior consultant in obstetrics and gynecology in the fetal medicine department at the Royal Hospital, Muscat, Oman. Dr. Mauza has, after graduating from Sultan Qaboos University, had her MRCOG from the Royal College in London in 2006. And then she completed her fellowship in fetal medicine at the Harris Birth Rate Center at King's College in 2011 and got her fellowship in 2019. She has been very well appreciated for her performance, outstanding performance in Royal Hospital and also the Ministry of Health. And she's also an international member of the International Society of Ultrasound and ONG. She was also the lead organizer for the ISWAG outreach training program, which was very, very successful, a very innovative method they did about connecting the trainer and the trainee. And Dr. Mauza is also a senior clinical trainer at OMSP and was also the local organizer for the MRCOG exams till 2018. And she's the founder and chairman of the Oman Society of Ultrasound and OBGYN. It's a great pleasure to invite her to initiate the proceedings with the guidelines for CNS examination, which has been issued by the new guidelines, which have been issued by ISWAG. Mauza, the floor is yours.
Thank you, Prof. Thank you for the kind introduction. I hope you can see my screen.
Yes.
Yes. So basically, in my presentation, I will try to give brief overview about the recent guideline which has been published by the International Society of Ultrasound in OB/GYN. The first guideline was published in 2021, and it was updated for the old guideline, and it covers the screening examination of the fetal CNS. And the second guideline, it was published in 2021 last year, and it gives us a brief protocol regarding the performance of targeted CNS. So why we need to cover such topics? As you all know, and as I have mentioned previously in my introduction, that fetal CNS anomalies are among the commonest congenital birth defects. And for reaching correct diagnosis, we need to have three important factors. The first one, that the examiner should be having the skill and knowledge regarding the developmental embryology of the fetal CNS, which actually change at various gestational age. And this is why one of the recommendations from the International Society is that the examiner should be familiar with the normal CNS appearance at different gestational age in order to reach correct diagnosis. The other important factor is the accurate determination of the gestational age of the fetus. And the third important factor is the use of systematic approach during the evaluation of the fetal brain. So this is just a slide showing you how important the examiner be familiar with the normal morphology of the fetal CNS at different gestational age. If you see here, and if you concentrate, for example, on the transventricular plane at different gestational age and concentrate on the choroid plexus and lateral ventricle, you can see how the morphology change from 12 weeks to 21 weeks and to 32 weeks. And this is why it's very important to be familiar with the normal morphology of the intracranial structures. So as I have mentioned, the first part of the guidelines concentrated on the screening examination, and they started with screening examination of the fetal brain after 18 weeks. In addition, they also covered the screening examination before 18 weeks and also the criteria for referring fetuses for neurosonography and MRI. So the recommendation from this guideline is to use the trans-abdominal approach for the screening examination. And with that, the recommendation is to use trans-abdominal transducer with a frequency of 3 to 5 megahertz. So no need to use a transducer with high frequency, unless, of course, the images are limited because of the gestational age or because of the maternal habitus. And the examination, the screening examination, can be performed using the 2D ultrasound. And these are the structures that need to be noted and documented during the screening examination. And of course, in addition to these qualitative assessment, they also recommended the use of quantitative measurements of following structures, which include the biparietal diameter and the head circumference, as well as the atrial width and the posterior fossa structure, including the transcerebellar diameter and the depth of the sternum inlet. So I will start with the first part from the guideline, which describe the screening examination after 18 weeks. And for that, they recommend 3 axial plane, the transventricular, the transthalamic, and the transcerebellar. So we'll start with the transventricular plane. In the transventricular plane, the examiner should note and document head integrity and the skull shape, as well as the examiner should check the anterior complex, look into the normal shape of the anterior complex, including the catham septum pellucidum, which usually have square shape, the anterior horn of the lateral ventricle and the corpus callosum, as well as the pars cerebri and the posterior horn of the lateral ventricle, including the choroid plexus. In addition, the examiner should also check for the lateral fissures, including the Sylvian fissure and the parieto-occipital fissure, which are markers for the normal cortical development. And this is just a slide showing you how important to be familiar with the normal appearance of intracranial structure. If you concentrate, for example, on the Sylvian fissure, you can see that the Sylvian fissure at 19 weeks is more of shallow bed, and then start the angle to be more obtuse, and then to be more acute at 27 weeks, and then the operculation or closure of the Sylvian fissure start after 13 weeks. And this is just a marker for the normal development of the cortex. It's also important is to get the correct scanning plane. And for transventricular, for example, the correct scanning plane is through the corpus callosum and catham septum. And sometimes we do get referral where the scanning plane actually taken through the columns of the fornix, which is give you a different appearance, almost similar to the catham septum pellucidum. But this is very important because in cases where there is absence of the catham septum pellucidum, may give you false reassurance. You may also get cases where the catham septum pellucidum looks small due to the absence of the fluid in the cavity, and this is normal variant in some fetuses. Absent catham septum pellucidum, either you will get separation of the anterior horn with T-drop appearance, or you may get fusion of the anterior horn. And these will be covered by the speakers in their talk. But it's important when you have such cases to refer them for details and neurosonography to reach correct diagnosis. The guideline also cover how to take the measurement of the atrial width for the posterior horn of the lateral ventricle, and the recommendation is to put the cursor inner to inner at the level of the parieto-occipital fissure to avoid either overdiagnosis or underdiagnosis of ventriculomegaly. The transthalamic plane is the second plane, second axial plane, and it is used to get the quantitative measurements of the biparietal and the head circumference. And in this plane, you will get the anterior complex, the thalami, the pars cerebri, the Sylvian fissure, and you can also see the hippocampal gyri. For transcerebellar plane, to get the transcerebellar plane, what you need is just to tilt your probe posteriorly to get the posterior fossa structure. And in this, it's very important to note the normal appearance of the cerebellum, which usually have butterfly appearance. where cerebellar hemispheres are connected in the middle by transcerebellar vermis that looks more echogenic compared to the cerebellar hemisphere. It's also important to know to check the cisterna magna with the tiny septations in between, and this is representing the remnant of the Blake pouch cyst. This just image show you how important it is to make sure that the cerebellar vermis shape looks normal compared with this photo which show you abnormal shape of the cerebellum. It's also important to make sure that both cerebellar hemispheres are symmetrical. These cases where you can see the cerebellar hemisphere are asymmetrical due to some infarct and because of vascular issues. It's also important to make sure that the cisterna magna is not obliterated, like in cases of open spina bifida, and that the cerebellar vermis cover completely the fourth ventricle, and there is no communication between the fourth ventricle and cisterna magna. Regarding the fetal spine, the recommendation, if possible and feasible with the fetal position, is to get the longitudinal mid-sagittal view of the spine, so you can check the integrity of the skin overlying the spine as well as the normal appearance of the vertebral body. What is important also is, if possible, to get also and check the spine in axial planes at different levels, looking to the ossification centers and in between the spinal cord. The second part of the guideline, they cover the screening examination of fetal brain before 18 weeks. And the recommendation is to document two axial plane, the transventricular plane and the transcerebellar plane. And you can see how different the transventricular plane from the one which is after 18 weeks. You can see that the lateral horns are more bigger compared to the surrounding parenchyma, as well as you can see that the choroid plexus occupy majority of the lateral ventricles. And in the transcerebellar plane, you can see that the shape of the cerebellum is different from that after 18 weeks. And you can see also the lateral, the anterior horn of the lateral ventricle, which is more round. So at the end of this guideline, they also mentioned the indication for referring the patients for fetal neurosonography. And they mentioned several indications. One of the indications is if you have suspicion of fetal CNS or spinal malformation at routine screening ultrasound or at anti-scan, or if there is family history of inheritable CNS or spinal malformation, or if there is history of previous pregnancy complicated by CNS anomalies. And in cases also when you have a fetus with congenital heart disease, it is recommended also to check and do detailed CNS anomalies. Fetal neurosonography also indicated in case of monochorionic twin, especially those complicated by twin-to-twin translucent syndrome, or those who had fetoscopy laser. In cases also of suspected intrauterine infection or history of exposure to teratogenic effects. Fetal neurosonography also indicated when you have also microarray results that give you findings of unknown significance. The second guideline covered the protocol for doing targeted neurosonography. And the general recommendation is to use the transvaginal approach because of such approach gives you images with high resolution. But if it is not feasible because the patient using transvaginal scan, or because the fetus is in breech presentation or in multiple pregnancy, then you can use the transabdominal approach. And with transabdominal, the recommendation is to use high frequency probes like the linear probe with frequency of 8 to 9 megahertz to get images with clear view for the intracranial structures. So we all know that the basis of neurosonographic examination is the multiplanar approach, which is obtained by aligning the probes with the fontanelles and sutures to get clear window for the intracranial structures. And you can get the planes either using 2D or 3D or together. And the guideline describe 4 coronal planes and 2 sagittal planes. We will go through them one by one. For the transfrontal plane, this plane can be get by aligning the probe with the anterior fontanelle. And in this plane, you can see the interhemispheric fissures, the frontal lobes, the sphenoid bone, and the orbits on either side. The second plane is the transpodate plane, and this is very important plane to check the anterior complex. And it is obtained just by tilting the probe toward the posterior edge of the anterior fontanelle. And it is one of the most important views in fetal neurosonography. It will show you, in addition to the interhemispheric fissure, the anterior complex, which include the corpus callosum, the anterior horn of the lateral ventricle, the catham septum pellucidum, and the caudate nuclei, as well as you can see also the lateral fissures. The transthalamic plane can be get through either the anterior fontanelle by angulation of the probe or through the open sagittal fissures. And in this plane, in addition to the anterior complex, you can see the thalami, the sylvian fissure, and you can evaluate also the hippocampal gyri on either side. The transcerebellar plane can be get through the posterior fontanelle. And in this plane, you can see the posterior horns, the parieto-occipital fissures, the interhemispheric fissure, and you can evaluate the posterior fossa, including the cerebellum, the cisterna magna. Now we will talk about the mid-sagittal and parasagittal planes. And the mid-sagittal can be obtained through by rotating the probe 90 degrees from the coronal plane. And the parasagittal plane can be obtained just by tilting the probe on either side when you get the mid-sagittal plane. And in the parasagittal plane, you can check the brain parenchyma, the lateral ventricles with the choroid plexus, as well as the lateral features. And the recommendation when we check the mid-sagittal anterior plane, which is usually we get it through the anterior fontanelle, which is very important plane actually to check the midline structures, including the corpus callosum, the catham septum pellucidum, the fornix, the third ventricle, and also the infratentorial structure, including the cerebellar vermis and the fourth ventricle. And the recommendation that when you check the corpus callosum, what is important is the qualitative assessment of the corpus callosum. So it's important to make sure that the 4 parts of the corpus callosum are present. No need to take measurements. What is important is the qualitative assessment, looking to the rostrum, the genu, the body of the corpus callosum, and the splenium, as well as the catham septum pellucidum, and in some cases you may also be able to see the catham pellucidum, which is the posterior part of the catham septum in this view. The mid-sagittal posterior plane is very important to assess the infratentorial structure, looking to the cerebellar vermis, the appearance of the cerebellar vermis, the fourth ventricle, as well as the cisterna magna, and also to check in some cases the aqueduct. Now we talk about the fetal spine, and the recommendation for this guideline is to check the fetal spine in, if possible, in 3 planes. The mid-sagittal longitudinal plane, looking to the spinal vertebra, the shape, as well as the skin integrity and the conus medullaris, as well as to check the spine in the axial planes at different levels. And if not possible to get the third plane, the coronal plane, then you can use the 3D to evaluate the spine and to get more clear view regarding the spine. 3D can be also used to check the intracranial structures in better resolution and to correlate structures at different planes. Now I talk about the neurosonography at 13 weeks. And the recommendation is to use a two axial plane, the transventricular and the transthalamic. And we can use the 3D to correlate the structures. It will give you better correlation when you correlate the structures in the coronal and sagittal view. Like in this case, for example, you can see nicely the aqueduct and the fourth ventricles, and you can see also the Blake pouch in communication with the cisterna magna and the choroid plexus. But 2D, when you evaluate the NT, you can also check the intracranial structures. And in this, for example, view, you can see the thalami, the brainstem, and the fourth ventricle, which usually used indirectly to exclude spinal bifida at the gestational age. Regarding the neurosonography at 15 and 16 weeks, you can use either 2D or 3D, the axial and the sagittal, and you can check actually at 16 weeks, you can check the initial part of the choroid of the corpus callosum and the catham septum pellucidum, and you can see also the catham interbosity at this stage. So in conclusion, fetal neurosonography, it helps you to look at the brain in more detail using multiplanar approach with either with both 2D and 3D. And for such examination, you can use either transvaginal and or transabdominal with high frequency probe. And of course, to do such examination, you need expertise who have the knowledge and skill in doing such examination. Fetal MRI can be used as complementary when a question is raised by the neurosurgeonist. And this is why it is not routine to order for fetal brain MRI unless you don't have neurosonographic who have the skill to do a detailed CNS evaluation. And in such a setup, when you have abnormal finding in the screening examination, yes, you can go for the fetal MRI. So thank you for listening, and I hope you had clear view about both guidelines.
Thank you, Dr. Musa. Do we take some questions now, or what do we do?
We can leave it. We have at the end of the session time to discuss all the things.
Yeah, the request from the audience is that the slides are changing very fast. There's no time to read everything because there's a lot of information on the slide. So that's the only feedback we have. So let's move on to the next speaker, and it's my absolute pleasure to invite Dr. Divya Singh. Dr. Divya Singh is a radiologist from Chandigarh. She has finished her MD in radio diagnosis at the Postgraduate Institute in Chandigarh, and she was also a senior resident in AIIMS, New Delhi, and done her fellowship in advanced OBGYN ultrasound from Mediscan, Chennai. Now, Dr. Divya Singh is a consultant radiologist at the Prime Imaging and Prenatal Diagnostic Center in Chandigarh, and also an OBGYN ultrasound content expert at Intleos ARDMS USA, and member of the ISWAG CME Task Force on Online Education Working Group, and member ISWAG Basic Training and Outreach Working Group. She's been awarded by the Ministry of Health and Government of India for providing exemplary service to pregnant women in Chandigarh in 2018, and also has got a best oral paper presentation, ultrasound and endometriosis. She has 52 publications and 2 book chapters. More importantly, Divya is an excellent and very passionate teacher, and she's very, very popular in India for the quality and content she delivers whenever she's asked to. So we're very happy that she consented to deliver this lecture on malformations of cortical development. Divya?
Good afternoon, everyone, and thank you, sir, for the overwhelming words of introduction. I hope to do justice to your kind words in the subsequent slides. At the outset, I congratulate Dr. Moza and the Oman Society of Ultrasound and Obstetrics and Gynecology for organizing this academic treat on this weekend. And thank you for the kind invitation. I'll be speaking on malformations of cortical development. And before I start speaking on the malformations, it would be a good idea to get a bird's eye view of how the normal cortical development takes place. I'll be giving you a simplified approach towards this little complex process, but the normal cortical development begins in the second trimester of pregnancy and involves three overlapping processes. First, there is neuronal proliferation, that is proliferation of the neurons in the region of the periventricular zone or the germinal matrix. Here, the neurons multiply and then they start migrating to form the future cerebral cortex. So there are three processes, that is process of neuronal proliferation, neuronal migration, and finally cortical organization, which results in the formation of the normal six-layered cerebral cortex. Now, any insult in these three processes can lead to malformations of cortical development, as we'll see in the subsequent slides. Now, there are certain challenges in the antenatal diagnosis of malformations of cortical development. As you understand that this is a process which begins in the second trimester of pregnancy, the sonologic signs of MCDs may become evident only in the later part of second trimester or in the third trimester. Also, one needs to be aware of cortical milestones, that is, normal milestones of development of the cerebral sulci and gyri before one can pick up these abnormalities. As you know, we scan the brain in an axial plane when we are doing a screening examination. And some of these malformations may not be that evident in the axial plane and therefore require a multiplanar evaluation of the brain, as explained lucidly by Dr. Musa in her presentation. Also, sometimes these conditions are accompanied with severe abnormalities like gross ventriculomegaly, agenesis of corpus callosum, which would result in early termination of these pregnancies even before these malformations could become evident on ultrasound. That being said, it is still possible to detect many of these malformations by ultrasound in the antenatal period, and let us see how we can go about doing this. Now, when should you start looking at the cerebral cortex of the fetus for malformations of cortical development? Well, if you see a head circumference which is less than the 5th or greater than the 95th centile for that period of gestation, please look at the brain in greater detail. If the ventricles are dilated, be it mild or severe, or if they are asymmetric, this should prompt you to look at the fetal brain more carefully. Abnormalities of midline intracranial structures like corpus callosum and cerebral vermis should also prompt you to look for these MCDs. In addition, presence of multiple extracranial anomalies are another red flag. Now, what are the signs that you would see on ultrasound in the brain in case of a malformation of cortical development? There can be abnormal appearance of cerebral sulci. Now, you must remember that cerebral sulci, the various sulci, they differ in the time as well as their morphology during different periods of gestation. So if you see sulci too early, or you don't see the sulci which are expected to be present for that period of gestation, or they look abnormal in appearance, then it is highly suggestive of a malformation of cortical development. In addition, look at the ventricular walls. Irregularity in the ventricular walls, an asymmetric cerebral hemisphere, which has an irregular surface, or focal brain lesions like a nodule or a cleft are all sonographic signs suggestive of malformations of cortical development. Now, before you even start looking at the brain, there is one thing that you must always remember, and that is that the pregnancy should be dated correctly, because all this cortical development will be interpreted in the context of the period of gestation. So if you don't get that right, then your entire examination goes for a toss. Now, this is just a table to show you the timeline at which the various sulci are seen in the brain in majority of fetuses. If you are somebody who's starting your journey in the evaluation of the fetal cerebral cortex, it's a good idea to first focus in the axial plane on these two sulci, which are seen at the time of the mid-trimester scan in majority of the fetuses, that is the Sylvian fissure and the parieto-occipital sulcus. Now, this is a table which shows you the various common fetal sulci and the planes in which they would be seen very well. And let us now try to look at the common sulci in the various planes. I shall be starting with the axial plane. And if you were to take a sweep of the brain from the top to bottom, on the most cranial section, you would see this linear echogenic structure, which is the interhemispheric fissure, which separates or rather divides the cerebral hemisphere into two equal halves. And you know that you can see this fissure as early as 11 weeks, and it's quite evident even in the first trimester exam. If we go a little more caudally in the brain in the second trimester, you can appreciate the parieto-occipital sulcus, which we all know is the landmark for measuring the atrium of the lateral ventricle. If we go more caudally, then we can appreciate the Sylvian fissure seen here. In the coronal planes, it becomes a little more complex. But let us look at some common sulci that we can appreciate in these planes. And I'll be starting with the most posterior section and then moving anteriorly. Also, it is good to know that many of these sulci, for instance, the calcarine sulcus, would be seen only around 22 weeks of gestation. So if you try to look for these sulci at 18 weeks, you won't see them, because normally there are only two sulci seen at around 18 weeks, namely the parieto-occipital and the Sylvian fissures. And calcarine sulcus is seen in the most posterior plane, that is the plane of the cerebellum, as these echogenic linear structures on either side of the occipital horn of the lateral ventricles. When we go more anteriorly, we can see the callosal sulcus, and as the name suggests, it is seen in relation with the corpus callosum. The normal corpus callosum in the coronal plane is this hypoechoic linear structure which bridges both the cerebral hemispheres, and the callosal sulcus is this echogenic linear structure above the corpus callosum. The cingulate sulcus is identified very easily once you've identified the corpus callosum and the callosal sulcus. The next sulcus above it on either side, these are the cingulate sulci. And finally, if you go more anteriorly, as you can see here, we've reached almost the level of the fetal orbits. If you look at the base of the brain here, you can appreciate the olfactory sulci. These are typically seen at around 30 weeks, that is in the third trimester of pregnancy. And they are important because they may not be seen in certain conditions affecting the olfactory system, like the Chard syndrome. Then looking at these sulci in the sagittal plane. Now, this is a mid-sagittal section of the fetal head in the third trimester, and this hypoechoic structure that you see here is the corpus callosum. As expected, this echogenic structure above the corpus callosum would be the callosal sulcus. And if you were to go slightly parasagittal, you would see another echogenic structure above the callosal sulcus, and this would be the cingulate sulcus, which normally courses superiorly towards the surface of the brain. So this is the cingulate sulcus in the sagittal plane, and below the cingulate sulcus lies the cingulate gyrus. So these are some of the common sulci that you must be aware of if we are to embark on evaluating malformations of cortical development. Also, you should know how the morphology of the sulci changes with advancing gestation. As you can see here, the parieto-occipital sulcus begins as a dot here at 20 weeks. It becomes V-shaped as we progress in gestation, and finally in the third trimester has a Y-shaped morphology. This is true for all sulci. The Sylvian fissure, as pointed out by Dr. Moza, looks a little different because there is operculization, that is folding of the frontal, temporal, and the parietal lobes of the brain to form the insula. And at 18 weeks, the angle between the posterior part of the Sylvian fissure and the temporal lobe is obtuse. That is, this angle is more than 90 degrees. At around 24 weeks, this angle becomes nearly perpendicular. And in the third trimester, the angle is acute, the angle between the posterior part of Sylvian fissure and the temporal lobe. And again, this is something that one should be familiar with. Now, armed with this knowledge, we embark on the classification of malformations of cortical development. And the first group of conditions is those in which the proliferation of the neurons in the periventricular zone is disturbed. Now, if the proliferation is less than normal, the head size as expected would be small, and the condition resulting thereby is microcephaly. On the other hand, if there is overproliferation of neurons in the periventricular zone, we would have megalencephaly and hemimegalencephaly. Now, if the problem was not in proliferation, but in the migration of neurons towards the cerebral surface, and if this were to occur early on, then the neurons would remain confined in the periventricular zone, and we would have what is known as periventricular nodular heterotopia. On the other hand, if the migration of neurons was affected slightly later on, then the neurons won't reach the cerebral surface won't have the classic sulci and gyrations, and we would get a smooth brain typical of classic lissencephaly. Remember, these neurons are limited by the pia matter, which prevents them from migrating. It stops them and instructs them to organize themselves and form a six-layered cortex normally. However, in certain conditions, this resistance or this limitation by the pia matter doesn't take place. The neurons over-migrate and result in what is known as cobblestone malformation. And finally, failure of cortical organization results in polymicrogyria and focal cortical dysplasia. Now, the various causes of these malformations or the various insults which could lead to malformations of cortical development are genetic, and they constitute a substantial bulk of the cause of MCDs. However, there are other conditions like infections caused by viruses which have an affinity for the brain, like the cytomegalovirus and Zika, metabolic disorders, maternal drug abuse, and vascular conditions, which can result in MCDs. Now, coming to microcephaly. We all know that microcephaly in fetal life is defined as when head circumference is less than 3 standard deviations below the mean. The head is small because there is underproliferation of neurons in the periventricular zone. And there can be two types of microcephaly. Primary, when the problem is inherent in the brain and the rest of the structures are normal. And secondary microcephaly, when there are not only abnormalities in the brain, but also in extracranial structures. And this occurs because of some condition which affects the normal process of brain development. For instance, CMV infection. Now, it not only affects the brain, but it affects other organs. But when it damages the brain, it results in secondary microcephaly. The problem with primary microcephaly, that is when the problem is just confined to the brain, is that it may not be evident till the 3rd trimester or even may be detected postnatally. So it's a good practice that if you come across a fetus during scanning whose head circumference is less than the 5th centile, and you've checked the parent's head, that both the parents do not, either of them doesn't have a small head, then it's a good practice to repeat the scan and follow up the fetus after 4 weeks to look for how things progress and whether the growth trajectory of the head circumference is maintained. These are some of the common genes which are implicated in causation of primary microcephaly. And I'll be showing you this fetus at 24 weeks, which we saw recently. As you can see, even if you eyeball, the head looks small for 24 weeks. And as I scanned from top to bottom, this is the only cerebral hemisphere. I mean, this was the entire cerebral hemisphere. It was quite small for 24 weeks. There was no sulcation, which should be seen at this point of time. But if you looked at the posterior fossa, that is the cerebellum, the cisterna magna, they appeared normal in morphology, but the transcerebellar diameter was less than the 1st centile. And obviously, this fetal head was very small. It was below 3 standard deviations for 24 weeks of gestation. And this was a case of primary microcephaly. There was no abnormality elsewhere. And if you saw the sagittal view of the fetal face, you can see the typical sloping appearance of the forehead because of a small brain size. Coming to megalencephaly, the other end of spectrum, when the head size is greater than 3 standard deviations above the mean. Hemimegalencephaly is a condition in which the involvement is confined to just half of a cerebral hemisphere or even just a part of a cerebral hemisphere. And besides this difference in size or a big head, there is also accompanying abnormalities in the sulci and gyration. As you can see in this case taken from literature, this was a fetus which presented with a huge head, more than 6 standard deviations at 20 weeks of gestation. But besides the fact that the head is big, you can also appreciate that the ventricles are dilated, they are asymmetric. So this should prompt you to look at the brain closely. And in the coronal plane, you can appreciate the presence of these unusual sulci, which should not be seen at this time at 20 weeks. And this is a case of megalencephaly, which occurred due to a mutation in a gene, which is a tumor suppressor gene, which inhibits cell proliferation. And as a result, there was uncontrolled cell proliferation in the periventricular zone, resulting in megalencephaly in this case. Coming to periventricular nodular heterotopia. Now, if you remember, as the name suggests, you would see gray matter nodules along the ventricular wall because these are neurons which have failed to migrate early on. And the clue on ultrasound would be an irregular ventricular wall. If you see bilateral symmetric periventricular nodular heterotopia in a female fetus, it is quite suggestive of X-linked filamin A gene mutation. And the thing about this is that you must image the parents because the parents, the mom, may also show similar findings. What is interesting about this condition is that though the findings in the brain are quite remarkable, the parent might be totally asymptomatic. Now just see how the brain looks like in this condition. A coronal view of the brain, the ventricles definitely look abnormal. They are more dilated, have a square shape. And if you can appreciate this irregularity, this is the irregular ventricular wall, which you can confirm in the second plane, that is in the sagittal plane. The ventricle looks quite irregular, the wall of the ventricle. This is the control, that is the normal ventricular wall. It should be smooth, while this is not. Another fetus, and you can appreciate in the axial plane of the brain this irregular ventricular wall. This was confirmed on fetal MRI, where you could see these hypo-intense nodules, see how similar they are in appearance to the cerebral cortex. So these are the neurons which have failed to migrate and reach the cortex, a case of bilateral periventricular nodular heterotopia. And when the mother's MR was done, she was also found to have the similar condition, though she was completely asymptomatic for the same. Coming to the next entity, lissencephaly, that is a smooth brain. So it will be a brain in which the sulci would either be totally absent or deficient. And typically it involves the brain in a symmetric fashion. The earliest clue to lissencephaly can only be mild ventriculomegaly. So this is your red flag. It should prompt you to look at the sulci carefully, especially the Sylvian fissure, and you might see delayed operculization. It can have a complete form when the entire brain is affected, or incomplete form in which either the anterior or the posterior part is more affected. There are certain genes, and based on the morphology or the type of lissencephaly on imaging, you can actually predict which type of gene is likely to be responsible. Now let us have a look at this fetal brain at 26 weeks. So first we confirm the period of gestation, it is 26 weeks, and then we have a look at this coronal section of the brain. On one look, we can see that the Sylvian fissures are quite shallow, they're not operculized, and this is a control for comparison. This is how the Sylvian fissures should look like at 26 weeks. There is also sulci present in the temporal lobe. This is a smooth brain devoid of normal sulci with shallow Sylvian fissures, which is quite typical of complete lissencephaly. The sibling of this fetus also had global neurodevelopmental delay, and the CT was suggestive of the complete lissencephaly, which has a very classic figure of 8 appearance. Another fetus. What prompted us to detect lissencephaly in this fetus at 20 weeks were the following findings. Now, the ventricle wasn't dilated, but there was presence of this echogenic halo in the occipital region. Also, the cortex appeared more echogenic and thick as compared to the normal control. In this control, you can see the normal operculized Sylvian fissure for 20 weeks. It is obtuse as expected. But lo and behold, in this case, the Sylvian fissure was not seen at all at 20 weeks. And this was a fetus with lissencephaly presenting at 20 weeks. Coming to the next malformation, in which there is overmigration Now, the neurons extend beyond the pia mater and result in cobblestone malformation. Now, the hint to cobblestone malformation is actually the associated findings of hydrocephalus and cephalocele. So when you see these conditions on CNS examination of the fetus, please look carefully at the fetal cortex. The cortex or the brain parenchyma is usually thin with lack of normal sulci, and a very characteristic feature which you see only in the sagittal plane is a Z-shaped kinked brainstem. In addition, there can be associated cerebellar and ocular abnormalities. And the key postnatal feature of cobblestone malformation is occurrence of early onset muscular dystrophy. Now, this is one fetus which presented to us with severe ventriculomegaly at 18 weeks. As you can appreciate in this clip, the lateral ventricle was markedly dilated. The cerebral parenchyma was quite thinned out. You could not appreciate the sylvian fissure well, which should be seen at 18 weeks. The cerebellum, however, was normal. But if you go in the sagittal plane, because remember, this is a fetus with gross ventriculomegaly, you need to look at the brain in the sagittal plane. This is the region of the thalamus. This is the stretched midbrain. And this is the brainstem. Normally, the brainstem is just a straight line at 18 weeks. But in this case, the brainstem was kinked, as you appreciate here. This was a case of cobblestone malformation with a Z-shaped kinked brainstem. In addition, the fetus had a small right globe with presence of retinal dysplasia. Coming to the next malformation, polymicrogyria. As the name suggests, there will be multiple small gyri on the surface of the brain, and they can involve the brain in a symmetric or asymmetric fashion. It can be focal or diffuse. Now, these are particularly difficult to pick up because they are typically seen later on, because they occur later on in the process of cortical development, mostly seen in the late second or the third trimester. But you need to be aware of certain sites where you have to focus, the most common being sylvian fissure, and others being the basal frontal region. The clue to the presence of polymicrogyria is presence of sulci which are more in number, or if they are present earlier than expected. So if you see a number of sulci at 18 weeks, you should start suspecting polymicrogyria. In addition, the overlying arachnoid space is usually prominent. Now, these are two fetuses, both presenting with polymicrogyria. As you can appreciate here, in this fetus at around 24 weeks, there are too many sulci over the cerebral surface and the sylvian fissure is not seen. Note the prominent extraaxial CSF subarachnoid space in this region. In this fetus, there is bilateral, almost symmetric polymicrogyria involving both the hemispheres. In this case, there was also presence of this strand within the occipital horn, which is fairly specific for a brain condition, which will be discussed subsequently by Dr. Khalil. Now, this was a fetus who also had a cardiac problem and hence had 22q11 microdeletion. So remember, if you see an extra CNS abnormality, look at the brain carefully. Whereas this was a case of fetal CMV with bilateral polymicrogyria. With this, I come to the end of this presentation, and I hope I've been able to make you understand that it's very important to understand the normal cortical developmental milestones first, before we start looking for malformations. These malformations are a big spectrum of diverse causes, and they are usually evident in later part of pregnancy. But if you're aware of the red flags, for instance, abnormal cranial biometry, abnormal brain morphology, presence of cranial or extracranial abnormalities, which should prompt you to look at the fetal cortex carefully. Once you know what you have to look for, you will start seeing them ultimately. Thank you.
Thank you, Divya, for that absolutely lovely presentation. It's my proud privilege to introduce Professor Asma Khalil, who's my co-moderator. And Professor Khalil is a professor of obstetrics and gynecology, maternal fetal medicine at the St. George's University Hospital, University of London. She's a subspecialist in maternal fetal medicine, specialized in scanning women with complication pregnancy one of her unique achievements is on multiple pregnancy service. And if I remember correctly, she has worked very hard for creating twin charts for and established that doing twin charts is important when you interpret twin pregnancies. And she also a member of the Royal College, the British Maternal Fetal Medicine Society, the International Society for Prenatal Diagnosis and Therapy, and ISWOG, very active member. She's got more than 50 publications to her credit, and she's well quoted everywhere. And as far as research in fetal medicine, I don't think there's anybody in fetal medicine who does not know Asma. Reading a formal CV will not be appropriate, because when you speak to her, you can realize the volume of work and the number of projects she takes on, and it's quite amazing to see how each of those projects are being executed in a fantastic fashion. Thank you, Asma, for joining us, and the floor is yours now.
Oh, thank you very much, Professor Suresh. It's a pleasure to be here with you, and it's a pleasure to co-moderate the session or the webinar. The talks have been fantastic so far. And without further delay, I'm gonna carry on with the program. So it's my turn to introduce you now with your next. The next one is yours. So again, just I don't think you really need an introduction. I think you're very well known. But just to maybe a summary of your amazing and very impressive career. So you are a pioneer in the field of diagnostic ultrasound, established fetal medicine as a specialty in India with extensive knowledge and skills in all aspects of the specialty, established the Mediscan systems and built the laboratory infrastructure needed for support and diagnosis in fetal medicine. From the beginning, continues to provide a huge volume of free service to those who cannot afford care, stemming from a strong sense of social responsibility. Has been in forefront of private-public partnership, interacting with the government of Tamil, that in organizing and implementing screening programs, both antenatal and neonatal screening, besides training programs for doctors. I certainly had the pleasure to work with some of your trainees, and I was really impressed with the level of scanning. So I know that this training program is very successful. Established Fetal Care Research Foundation, it's an NGO to provide preventive, supportive, and curative care for birth defects. Established the Birth Defects Registry of India with a single-minded focus of reducing perinatal mortality and morbidity. Dedicated teacher who trained many doctors from India and abroad in this field, and established a state-of-art imaging software and involved in web portal to ensure standards in ultrasound reporting and education. Again, heavily involved in ISWOG activities, particularly educational activities. So I think I'm going to stop here. Otherwise, I'm going to carry on for the next hour talking about your CV and your career. But it's my real pleasure to introduce your next talk, which is focusing on abnormalities of the corpus callosum, the cavum septum pellucidum, and the holoprosencephaly. Really important topic. Thank you.
Thank you, Dr. Asma, for those words of introduction. Before I begin, I'd like to say that suddenly, if there's a temporary outage, I will join back in a few seconds. I've been noticing that in the last few minutes, something is happening here on Zoom. So today I'm going to talk to you about abnormalities of the CSP, corpus callosum, and holoprosencephaly. When we put all of this together, we can sum it up in saying that we are going to talk about the anterior echo complex and its abnormalities. Essentially, as we know, that in the last several years, a lot of focus of attention has come in identifying the anterior echo complex and specific abnormalities which are associated with that. Now, the anterior echo complex has about 8 landmarks. The first one is the interhemispheric fissure. Then we have the callosal sulcus, the genu of the corpus callosum, cavum septum pellucidum, anterior horns of the lateral ventricle, the germinal matrix area, the external angle of the frontal horn, and the periventricular white matter. We can image it in the axial plane and the coronal plane. So let's go in detail about each of them. The interhemispheric fissure is those 2 bright white lines which are disrupted by the cavum septum pellucidum. It separates the 2 cerebral hemispheres. It's linear and it is interrupted by the corpus callosum and the cavum septum pellucidum. The callosal sulcus is seen as a bright echo anterior to the genu of the corpus callosum and perpendicular to the interhemispheric fissure. So this is the area is the callosal sulcus. The third aspect we need to know is the CSP is anechoic. Sometimes we may not see it very distinctly on the axial scan, but it is certainly brought out well on the coronal scan. Now, when we talking about the corpus callosum, we always like to do a sagittal scan. And in the sagittal scan, switching on the color Doppler will help you to identify not only the corpus callosum, but switching on the color Doppler tells you about the pericallosal artery, which is seen as its characteristic shape goes all the way when we think the corpus callosum is appearing small or big, then we do the measurement. The next structure we want to see is the cavum septum pellucidum, which is the cavitation of the commissural plate. It develops together with the corpus callosum from 12 to 18 weeks, and it is actually visualized from 16 to 37 weeks, where the BPD of 44 to 88 millimeters. We can measure the length and the width of the cavum septum pellucidum, and the CSP ratio can be arrived at, which is length by width, which is normally more than 1.5 in the mid-trimester. The cavum septum pellucidum actually closes near term. The closure happens from caudal to rostral and begins by about 24 weeks or so. It is seen in about 85% at term and at about 15% at 6 months of postnatal life. So as you are aware that CSP changes with gestational age, by 15 to 16 weeks, you're very difficult to identify it. But by 17 to 18 weeks, we can start seeing the CSP. At 20 to 21 weeks, we are able to identify the entire anterior echo complex. And then as you grow along, as you go closer to 34, 35 weeks, we can see the CSP has become quite narrow with the closure happening from the rostral, from the caudal to the rostral area. Now, one pitfall in imaging the cavum septum pellucidum needs to be understood. If you take your probe to a more caudal to the transventricular plane, instead of the rectangular shape anechoic area, you can see the interhemispheric fissure with the columns of the fornix on either side, and this can be mistaken for the presence of the CSP. So we have to be careful that you should not angulate too caudally in the transaxial plane. Next, we look at the anterior horns of the lateral ventricles. The anterior horns or lateral ventricles are very distinctly seen as anechoic areas, and their direction is usually away from the midline. They appear coma-shaped or triangle-shaped, and the shape and size is influenced by the growth of the rest of the anterior echo-complex structures. And the sixth area we want to look at is the germinal matrix area. The germinal matrix is the area on the side of the anterior horn posteriorly, and is located in the chordothalamic groove, and is important to understand it is a very highly vascular area, and that's where hemorrhages can take place. Then we come to the external angle of the anterior horns, which is the almost the tip of the anterior horns of the lateral ventricle. They are usually facing away from the midline, and they should be anechoic, as you can see here. The eighth area we want to see is the periventricular white matter area. It's the area of the frontal lobe of the cerebral cortex. It's seen in relation to the anterior horns. And once we are able to identify all these 8 areas, we can now start looking at the abnormalities of these areas. So let's look at what are the abnormalities that can happen in the anterior echo complex. The first thing we want to look at is holoprosencephaly, where areas 1, 2, 3, and 4 are absent. That is, here 1, 2, 3, and 4 in the midline are absent. The interhemispheric fissure is completely or partially absent. The callosal sulcus is absent. The genu of the corpus callosum is absent. The cavum septum pellucidum is absent. And the anterior horns of the lateral ventricle are both fused with each other. And when there's complete fusion with no interhemispheric fissure at all, we call it as alobar holoprosencephaly. In semi-lobar holoprosencephaly, there is non-separation of the anterior hemispheres, and the interhemispheric fissure, less than 50% of the interhemispheric fissure is absent. So this is called a semi-lobar holoprosencephaly. And in lobar holoprosencephaly, the anterior horns of the lateral ventricle are fused with each other, and they are underdeveloped, and more than 50% of the interhemispheric fissure is usually present. MRI may show pituitary hypoplasia and also optic nerve hypoplasia. So you can have an isolated small or absent cavum septum pellucidum with evidence of fused frontal horns. This is probably the most difficult of all these holoprosencephalies to identify. And lobar holoprosencephaly may be difficult to identify at 12 weeks, probably have to go to the second trimester. Associated abnormalities could be T13 or 18 and more than 50%, genetic syndrome in greater than 20%, and mid-facial defects, microcephaly in alobar in about 80% or so. So you can see the proboscis, which can usually be seen as a mid-facial anomaly. You can have a flattened facial profile, which can also be seen. Karyotyping and microarray are warranted, and MRI is done only to confirm lobar holoprosencephaly, because the alobar type and semi-lobar type can be easily identified by ultrasound. The recurrence depends on the etiology, varies from 1 to 25 to 50%, depending on, in trisomies, for example, the recurrence is only about 1%. And in the presence of trisomy 13, 18, and genetic syndromes, obviously we'll see extracerebral defects also. Next, we come to the corpus callosum, which can be complete agenesis, partial agenesis. The corpus callosum can be thick or thin, and also there can be a lipoma of the corpus callosum, which is quite rare. In complete agenesis of the corpus callosum, the interhemispheric fissure is widened, the callosal sulcus is absent, the genu of the corpus callosum is absent, and the anterior horns of the lateral ventricle are widely separated with each other. So we can do that in the coronal view, where you can see the absence of the genu of the corpus callosum, and you can see the widely separated frontal horns, which is has a very typical appearance. As you go in the second trimester, sometimes you can see the frontal horns appearing as pinch structures, and the whole lateral ventricle has got a teardrop shape with the occipital horn being dilated and the frontal horn having a pinched appearance. Now, once you suspect a complete agent of the corpus callosum, we also do a sagittal view. And in this, you can see the absence of the corpus callosum, very distinctly identified. As you go later in gestation, you'll be able to see the radiating sulci. And switching on the color Doppler will tell you the absence of the pericallosal artery, which is easily identified. Now, partial agency of corpus callosum is maybe a little bit more difficult to identify, but a careful look at the CC will tell you the corpus callosum will be short in length, less than 18 millimeters, or very thin, less than 2 millimeters in thickness. In partial ACC, it usually involves a loss of the posterior parts, the body and the splenium. If partial agency is suspected, look for arachnoid cysts, posterior fossa abnormalities, and other structural malformations. So here are some examples of partial agents of corpus callosum, where you can see the midline forks is present. The callosal sulcus is absent. The genu of the corpus callosum, as said, may or may not be present. The cavum septum pellucidum is wide. Here you can see it's very wide. Here you can okay. I hope okay, I hope you're able to see the thing now. So in partial agents of corpus callosum, you can see a mid-sagittal view where you can see part of the pericallosal artery, and the part of the body is seen, and then the posterior part of the body and the splenium is absent. Right. Then we do an extended neurosonogram to a 3D multiplanar imaging, and also transvaginal imaging certainly helps to identify this condition even better. And additional CNS abnormalities, of course, have to be looked for. Now, the cavum septum pellucidum ratio, or CSP ratio, can be a marker for partial agents of the fetal corpus callosum. This is Rabi Chow's publication in 2017. They said out of 20 cases, 16 out of 20 had, with partial ACC, had a CSP ratio of 1.5. So this could be a useful marker when we look at it. Now, the implications of agents of corpus callosum is CNS anomalies in about 85%, extra CNS anomalies in 62%. Cardiovascular anomalies are mainly corontruncal, and ACC is part of Mendelian syndromes also. Chromosomal anomalies like trisomy 18, trisomy 13, and trisomy 8 occur in about 20% of the cases. How do we counsel patients? We tell them isolated ACC has a 30% risk of moderate or severe neurodevelopmental delay and about 30% recurrence risk. When associated with other CNS pathologies, the risk of neurodevelopmental delay is more than 50%. Then we look at thin corpus callosum. You can see a very, very thin corpus callosum, as you can see here, which is otherwise called as hypoplasia of the corpus callosum. And we really don't know the implication of this, but it has been implicated in some metabolic disorders. And when you see a bright echogenic area in the midline, in the region, in the frontal region, in the second and third trimester, then we think of a lipoma of the corpus callosum. It's quite rare, and more than 50% of the intrahemispheric lipomas or corpus callosal lipomas are associated with seizures starting in the second decade of life. Intellectual disability and psychological disorders may also develop later. And in the mid-sagittal view, this is from this publication in the White Journal, where you can see a thin, bright white line spread out, which can be confirmed by MRI. Now, the callosal thickness, we talked about the possibility of measuring the callosal thickness. And I'd like to look at the changing evidence that's published. In the year 2009, a thick corpus callosum was thought of as an ominous sign. This series of 9 fetuses with thick corpus callosum, and all had associated anomalies. And a thick corpus callosum is usually associated with other brain anomalies and is part of a neurogenetic syndrome in most cases, was the conclusion. Now, the same group in 2016, say they had a similar group of 9 cases with apparently isolated thick corpus callosum was included in the study. And their conclusions were apparently isolated thick corpus callosum is not necessarily associated with poor prognosis. In such cases, a definitive diagnosis should not be reached based on a single measurement, and repeat follow-up examination during the third trimester are recommended. What do we learn from here? And if you take neuroradiology, they said a thick corpus callosum could actually lead to corpus callosal dysgenesis and other problems associated with it. So what we understand from here is once you see a thick corpus callosum, a thorough search is made for other abnormalities. If it is isolated, probably we'll follow up expectantly. And if it's associated, we know that this is some multiple problems that we can expect long-term poor neurological outcome. Then we go to septal agenesis. Now, in septal agenesis, the area number 4, which is the cavum septum pellucidum, is absent. The midline forks is present. The callosal sulcus is present. The geno of the corpus callosum is present. The cavum septum pellucidum absent. Coronal view is the one which is going to help us identify this. When you do a coronal view, you can see the intermesh fissure, and you can see the geno of the corpus callosum also seen well. So the differentiation between septal agenesis and lobar holoprosencephaly is what needs to be understood. In septal agenesis, the midline forks is intact, whereas in lobar holoprosencephaly, the midline forks is disrupted. The anterior horns are well developed in septal agenesis. It's poorly developed in lobar holoprosencephaly. The frontal cortex is well developed in septal agenesis and is poorly developed in holoprosencephaly. The corpus callosum is always present in septal agenesis. It may or may not be present in lobar holoprosencephaly. And if isolated in septal agenesis, the prognosis is good, whereas in lobar holoprosencephaly, the prognosis is poor. So it's extremely important from the counseling point of view, we make this differentiation. Now, there are other conditions where absent CSP in ventriculomegaly, where there can be a disruption of the CSP. Here you can see a clefting of the brain, which is in season-cephaly, where you may not be, the CSP may not be visualized. When the CSP is not imaged, it could also be associated with ventriculomegaly or with parenchymal abnormality. For example, this is a porencephalic cyst, which is seen there, and an intrahemispheric cyst where the CSP was not imaged well. And this baby had a partial ACC with intrahemispheric cyst. Just to share a little bit of data from our own center, for about 12 years, we had 56,830 abnormalities. Out of this, 7,479 CNS abnormalities, abnormal CSP in 557 cases. 70% of them was absent CSP in the agency of corpus callosum. Partial ACC, a smaller number, isolated absent CSP in about 5%, narrow CSP in 13%, and prominent CSP in about 4% or so. So majority of CSP absence is in agents of corpus callosum. So what about associated anomalies and isolated abnormality? When there's an absent CSP, the associated anomalies are about 55% and isolated at about 45% or so. When there's a narrow CSP, 75% of them are likely to be isolated, 25% associated anomalies, and when there's a prominent CSP, 67% are likely to be associated with abnormality, and 33% are isolated. So this probably gives us a picture about when there's a narrow CSP, more likely to be isolated as compared is the germinal matrix area, the external angle of the frontal horn, and the periventricular white matter. So grade 1, a germinal matrix hemorrhage, intraventricular hemorrhage is grade 2 or 3, and also periventricular hemorrhage is grade 4. And you can see that in the sagittal and also in the coronal views as bright echogenic areas, which are distinctly identified. Now, there are also cysts related to the anterior echo complex in the area 6, 7, and 8. I said in the axial view and in the coronal. And also cysts associated with periventricular recombination. So I will leave you with some key messages. Abnormalities of the anterior echo complex include holoprosencephaly, agenesis of corpus callosum, septal agenesis, cysts, hemorrhages, and alterations due to other cortical malformations. A structured approach helps in better characterization of the abnormality and thus helps in arriving at a diagnosis of possible etiology. Thank you very much for your patient listening.
That was brilliant. Thank you so much, Suresh. Certainly very comprehensive, crystal clear. Thank you. There's a question from Dr. Solmaz. She's asking, at times I've seen all elements of the anterior complex. However, there seems to be a structure with the same echogenicity, like the choroid plexus inside the anterior horn. The follow-up exam have been normal in 2 cases that I had. Could you please comment on this finding?
Okay, I think all of us can comment on this. I feel that choroid plexus normally does not appear in the frontal horn. So if it is echogenic, then there's more chance of it to be a hemorrhage, which could be there in the frontal horn. Yes, when you see a hemorrhage which is fresh and echogenic, after some time it can change its character and it may not be seen after a while. So you can comment on that also, Asma, and Badar also, if you have any opinion on that.
I totally agree with you, and in my talk, I'm covering the also the intraventricular hemorrhage and the different grades of the hemorrhage. So hopefully that would clarify this point a bit more. Okay, Perfect. I can't see any other questions, but as we mentioned earlier, we will have a discussion at the end of the session. But meanwhile, to all the delegates, if you have any questions or comment, please type it in the Q&As or in the chat function. We'd love to hear from you. And again, if you want sort of to ask a question or a case that you came across and you find it challenging, you've got here opportunity, you've got a group of experts that might help you. Okay, so we're going to move on with the program. And again, it's my real pleasure to introduce the next speaker, who is Professor Ahmed Badruddin, who is the director of the Fetal Maternal Medicine Center in Doha. And he's a professor also of obstetrics at the Weill Cornwall Medical College in Qatar. He previously held the position of chairman of obstetrics and gynecology at the Women's Hospital, which is part of Hamad Medical Corporation, for 10 years. And prior to moving to Qatar, he was also a consultant obstetrician gynecologist with special interest in perinatal medicine and high-risk pregnancy in the UK. He's a founding member of ISWAG, a board member of the World Association of Perinatal Medicine, founder and president of the African Association of Perinatal Medicine, founder of the fellowship program in advanced training in obstetrics and gynecology, board member of the Fetus as a Patient Society. Not sure how much time you have, founding member of the Academy of Medical Educators and the regional director of the Ian Donald School of Medical Ultrasound. He published more than 50 papers in peer-reviewed journals, and he is editor of the basic book of ultrasound and obstetrics and gynecology. He's written many chapters in several books, acts as a reviewer for many international journals, and he gets invited to speak at many international events. He has many special interests, particularly in fetal growth restriction, anemia, fetal echo, and high-risk pregnancies, as well as fetal anomalies. And he's going to talk to us on posterior fossa anomalies.
Hello, everybody. I hope you can hear me. Thank you very much, Dr. Moza, for the kind invitation. And I'm so happy to see friends in this webinar. Dr. Suresh, nice to meet you after all these years of COVID and asthma. Nice to meet you, Asma, on talking this webinar. And I want to congratulate you on behalf of everybody here for being elected as a vice chair by President of the Royal College of Gynecologists. You made us all very proud. So thank you all. Today, I'm going to speak about posterior fossa. And I just came across this video, which I think is a very, very good video because it makes my life easy. It gives me excuses because the posterior fossa houses cerebellum, the BEMS, the post ventricles, cisterna magna, and the brainstem. And you can see from the video above that all the structure I mentioned, they lie and they are all surrounded by bones. So making visualization is a little bit tricky. And if you look at the image below, you will see here the typical transcerebellar view we get in everyday practice. And that will show you posterior fossa, but not in great details. Now, I just want to mention some facts, and I call it fact sheets. Fact number one, that the brain size change, the brain change in size in an appearance through gestation. And this is a typical textbook picture. So they show you the brain size. And the implication of this, that the ultrasound appearance of the brain will not be the same. So you have to get familiar to the brain shape and size at every particular gestation. The fact number two, that the axial views, which you and me do every day, many times every day, axial views of the fetal head are merely for screening. This is extremely important. If you look at the slide here, we know there is the main thing we do every day is axial view, sagittal view, and coronal view. But what we do every day really is the axial view, looking for either transventricular, transthalamic, and transcerebellar views. And for the posterior fossa, the one which I'm concerned about is the transcerebellar views. These views are good enough only for screening, because that's what you get in the transcerebellar views in axial view, and that is the typical cerebellum, the BEMS as a dot, and then the fourth ventricle in front and cisterna magna behind. So this is a view which will help you to screen for abnormalities in the posterior fossa. But because they asked us to go on a deep dive on the CNS, I'm going to dive, but I'm not going to dive too deep because I think the majority of people listening to us are going to be people like myself who are doing a routine screening and scanning for malformation. And I'm not going to claim that I'm expert in neurosonography. I'm not like probably like Suresh or Asma or Jessica Kapoor. So, but that's why I'm gonna try to dive, but not to dive deep, and try to make maximum use of transcerebellar views, which you and me do every day. Look at this simple video. You can see what I'm talking about here. Here it is a transcerebellar view. You can see a cerebellum, the BAMs in the middle, and I just want to show this video to draw attention to these structures here. You can see this septa or the stria, whatever you want to call it, but there is structure here. These are the walls of the plaque pouch cyst. So if you get yourself familiar to these pictures, then probably going to make it easier when you have a malformation. So it's not only looking at cisterna magna as a hypoechoic space, but look at this small structure here, which are the wall of, could be the wall of plaque pouch cyst later on. Now, what do you see in transcerebellar views? As I said before, you see cerebellar hemispheres, the peduncles, you see the BAMs, you see cisterna magna, and the fourth ventricle. The fourth ventricle is critical for me because the fourth ventricle can give you a marker and a surrogate marker for the condition of the BAMs. The BAMs is difficult to visualize, but you can, I think all of us see the small echogenic area here, which is like a box here called the fourth ventricle. So if you get yourself familiar to this, it will be very helpful. So the last thing in the fact sheet I want to mention about high-risk patient for CNS malformation. And they are the ones who will require neurosonography. These are the ones who will require somebody, not only with expertise, but high-end machine. And it's based on a multiplanar approach. You get your introducer, you're going through either the fontanelle, anterior fontanelle, posterior fontanelle, or sagittal suture, and you have to have the experience as well as high-end machine. So what are the indications for neurosonogram? What is sonogram? I just told you it all depends on getting a multiplanar approach through the sutures and the fontanelle. Which patient will require neurosonogram? My friend, Dr. Moza, mentioned it, so I'm not going to repeat it. Just to mention, probably the most important one is when you suspect abnormal CNS finding on the routine axial view. That is probably the main indication for neurosonogram, plus the usual ones like family history, like previous pregnancy accompanied by brain problems, like babies with congenital heart disease, etc., etc., etc. But what you do every day, or probably just like me, you're going to be doing a scanning like this baby, for example, and you find rhabdomyomas. If you're having a rhabdomyoma in the heart, which is a benign condition, then we would like to know whether there is cranial involvement. Is the brain normal or abnormal? Basically, if baby have got rhabdomyoma, does this patient have tuberous sclerosis? And if you want to see the brain lesion, the tuberous sclerosis, these axial views will not help you. That will be a clear indication for neurosonogram. Another condition like here, you're scanning a patient, routine scanning in your unit, and you can like baby like that, which we see every day, hydraulic baby. You get edema of the head, scalp edema, you get ascites, you get brain effusion, you get pericardial effusion. This baby may also have a brain lesion, probably a cyst or a mass, which I'm sure Dr. Asma will talk about it in details, but that will be an indication for neurosonogram. So there is no escape of the fact that at some time you need to have a deep dive on the CNS. So neurosonogram or neurosonography is a multiplanar approach, as I said, depending on getting your views through sagittal view or the anterior and posterior fontanelle, and you acquire a volume, what we call a 3D volume, and then you can analyze the volume away from the patient. This is a typical textbook picture where you get these nice views, and my concern is only with the posterior fossa today. So if you want to do a proper assessment of the posterior fossa, then you have to get through the brain, either sagittal views or the fontanelles. The axial views will not help you. The question about transvaginal or transabdominal ultrasound, I think, has been addressed. And if you are lucky enough to have the baby in pre-presentation, you can try to get mid-sagittal views abdominally, but we're going to require a transvaginal scan most of the time. And I deliberately put this picture of my good friend Jessica Boo, just to get the chance to acknowledge her contribution, because I think she did more than anybody else in the field of neurosonogram. Her amazing pictures, her amazing views are really outcome of a very experienced person using a very high-end machine. When you're using the vaginal ultrasound to get these sort of nice pictures, you have to press really on the fontanelle, and you have to have a very good high-end machine. So this is sort of you're going to get if you get a very good picture through the fontanelle. You're going to get to see the occipital horn, you see the tentorium, you're going to see cerebral hemispheres, you see the VIMS in details, and you're going to see cisterna magna. So the optimal approach to posterior fossa will be through transvaginal ultrasound. And that is very simple, because we know from before that frequency and penetration are interdependent. So if you increase frequency, you decrease penetration. If you increase penetration, you decrease frequency, and vice versa. So if you use vaginal scan, we do not need penetration, so we can increase frequency. You have to apply a little bit of pressure on the transducer to get a good views, to avoid shadowing as well. And look for the fontanelle, anterior fontanelle, or posterior fontanelle, or sagittal suture. Otherwise, you will not be able to get good views. And you should use the other hand to steady the head when you're doing transvaginal scan, and always use VCI, volume contrast image. Now, what are the things which happen in the posterior fossa? Now we come to the real meat. The posterior fossa can be normal, or it can have Dunning-Walker malformation, which is the commonest. It can have VIMS hypoplasia, which is the least common. It can also have plaque bowel cyst or cisterna magna. And I'm going to speak about the first three, and I'm not going to speak about cisterna magna for the sake of time. And I just want to repeat, if you look at this normal, typical view of the transcerebellar views here, you can see clearly the cerebellum, the VIMS in the middle. And I again wanted to remind you to look all the time for this structure, which is the walls of the plaque pouch, and also to look in front of the VIMS for the false ventricles as the surrogate markers for normality of the VIMS. So when you look at to evaluate the posterior fossa, there's really three questions you want to ask yourself. The first one, is the VIMS normal in appearance and in size? And if they are normal, are they in the same place or rotated? And then the different question about tentorium cerebri, is it the same place or abnormal? Tentorium cerebri. So these are the fundamental questions to make you able to separate these four conditions which affect the posterior fossa. So if I start with plaque pouch, I said here we have Dunning-Walker, VIMS hypoplasia, plaque pouch, or megacisterna magna. If we start by plaque pouch cyst, and what we're going to see in plaque pouch cyst. In plaque pouch cyst, there's a clip here showing the keyhole appearance, which could be a case of plaque pouch cyst. Here you're going to see the VIMS is normal in size and in shape. You can see the coil plexus in normal position. You can also the keyhole signs here, the keyhole signs of the plaque pouch cyst, and the fluid is completely translucent. And here you go. Here is what I keep telling you about this septa, which is the wall of plaque pouch, and this is the plaque pouch cyst. So in normal cases, if you want to be able to diagnose abnormality, you have to get familiar to the normal appearance of the cisterna magna space. The cisterna magna is not empty. You've got this septa, which is the future walls of plaque pouch, if there's a cyst. Now, these are coronal views of the plaque pouch, and you can see with the multiple images. These are one of complicated images. I don't get these images every day, and I struggle to get these sort of images myself. So the questions we ask, is the VIMS rotated? The answer is yes. Is it in terms of cerebri elevated? I don't know, but it's no. Is the VIMS normal? The answer is yes. So the only problem we have here is plague pouch cyst, is that there is a little bit of change in the position of the BEMS. And that's about it. So the plague pouch is caused by lack of fenestration, they say. The normal cerebellum, it is prodic in nature, and it can present as hydrocephalus in the natal period, but the prognosis is very good. So it's quite important to be able to make a diagnosis of plague pouch cyst, because then you can straight away reassure your patient that the prognosis is generally very favorable. And as I said before, you can diagnose plague pouch cyst, in my view, relying only on the routine axial view through transcerebellar views. Now, what did we learn from systemic review regarding plague pouch cyst? Number one, that the CNS malformation is about 12%, non-CNS about 25%, but the chromosomal malformation is quite low. And there is no or rare any midodontal delay. And that is probably the most important thing, because you will exclude CNS malformation and non-CNS malformation by scan. So to be able to reassure your patient in the first visit that probably the baby will develop normally is quite important. Now, if I move to the next condition, which is WEMS hyperplasia, the good news is the least common, but that's the most difficult one to diagnose, at least in my hands. And you can see here, if you use the axial view, I repeat this view many times, you can only see the WEMS as a dot, no more information in the routine transcerebellar views. And here you go. Here you can see, I show you everything here. You can see that the transcerebellar views. And here you can see we try to be more sophisticated and using trans-sagittal views and getting a shape of the WEMS in more details. And that is the pathology specimen. So we can see moving from just a dot here for the WEMS to a very detailed, appearance of the WEMS if we move our examination and use the transvaginal ultrasound and probably go through the fontanelles or sagittal sutures and develop multi-planar approach. So WEMS hyperplasia, what is the right plane to get the views I've just shown you? Is it the transcerebellar views? I think we'll all agree that the transcerebellar views is not the right view to evaluate the WEMS, because it shows the WEMS only as the dot and nothing else. What about the transcerebellar views? Can we do anything about it? The answer is yes. I just mentioned to you that if you look at this point here, you can see this is a cerebellum and this is a box here. Hypoxic structure box here is called the fourth ventricles. And the fourth ventricle is a good marker of the WEMS condition. If the fourth ventricular index is normal, then the likelihood that this WEMS is normal. So what is the fourth ventricular index? You can see this small area here. These are called the fourth ventricles. If the lateral diameter is longer than the anteroposterior diameter, the fourth ventricular index is normal, and this is a good marker that the WEMS is normal. Again, the question remains: is the transcerebellar diameter the best view to assess the WEMS? The answer would be no. But at least this will give an indication of the condition of the WEMS using the fourth ventricular index as a marker for normal WEMS. This is a better view, transcoronal view. You can see here the occipital horn. You can see the tentorium on those sides. You can see the cerebellum on both sides, and then you can see the WEMS here. But again, it's not clear labulations. There is no clear size to it. It's difficult to assess. So transcoronal view plane is better than the transcerebellar view, but it's not the Atmos. The Atmos plane to assess the WEMS would be the mid-sagittal plane, this one. You have to get this mid-sagittal plane, and then you can see here the WEMS at the bottom here. And then you can measure the size of the WEMS, and you can assess the labellation of the WEMS. So as I started at the beginning, that WEMS assessment will not be easy. And that's why it's my routine practice to rely heavily on the fourth ventricular index as at least initial assessment of the WEMS. And here you see one of the cases where there is a severe WEMS hyperplasia. And this case went on to be showed really severe malformation. You can see completely against of the BEMS. So what do we learn from systemic review regarding the BEMS hyperplasia? We knew BEMS hyperplasia is not a common condition. It have got more than 50% chance of CNS anomalies association, more than 50% chance of non-CNS anomalies, and the chromosomal malformation is very, very low. Regarding the new developmental outcome and the future of these babies, is really hard to predict. Very hard to predict. It's very variable. And you rely heavily on the CNS malformation and non-CNS malformation to make assessment of this baby and whether the baby needs terminated pregnancy or not, and what to tell the parent, because you're relying on the BEMS condition by alone is difficult to predict. And as we all know, the BEMS is responsible for maintaining your posture more than anything else. The last thing I want to discuss, and I don't like to talk for a long time, is to speak about Dandy-Walker malformation, which is the most common. Again, Dandy-Walker malformation, you can look here, this is the typical transcerebellar views which you see every day. Does not help us very much. It may indicate to us that there is something wrong with the posterior fossa. Now, the Dandy-Walker malformation have classical triad. We all know about it. There is a partial BEMS hyperplasia. There is dilatation of the post ventricle and the large posterior fossa with upward rotation of the BEMS and tentorium elevation. So the tentorium, if you get to know how to look at the tentorium, you are done, because that is the second largest dural fold which we see. And it's completely abnormal in case of Dandy-Walker malformation. So there is a problem with the BEMS. There is a dilatation of the post ventricles, and also there's enlargement of the sterna magna area. And this is one of the patient with one of my old patients of Dandy-Walker malformation. And you can see probably the suspicion of the diagnosis is not very difficult. It's easy to tell that there is abnormal posterior fossa. The difficulty is which is which. Now you can easily tell these are abnormal, but which one is going to be difficult. Now, what do we learn? What do you know about from systemic reviews? That Dandy-Walker is associated with more than 10% CNS malformation and more than 40% non-CNS malformation. And look at that, 17% chance of abnormal chromosomes, and the neurodevelopmental of the baby is quite bad. So Dandy-Walker malformation, compare that to plaque pouch cyst, is completely different. And that's why it's very important to make a diagnosis of which is which in the posterior fossa. And this, I try to make a summary of what I said. So posterior fossa can either be normal or can have Dandy-Walker malformation, where there is hyperplasia of the BEMS, large fluid volume, high incidence of tentorium, high insertion of tentorium. Or it could be famous hyperplasia, where the BEMS is small, there is a mild rotation, and there is normal tentorium insertion. Or it could be plaque pouch cyst, where the BEMS is normal, the elevation is normal, but only there is a mild rotation of the BEMS, and this condition is quite benign. This is the summary of the finding in the posterior fossa. What is my take-home message? One, posterior fossa is not easy to diagnose. The most common one is Dandy-Walker malformation. Your axial routine plane is not sufficient, but it may help you, especially if you look carefully at the fourth ventricle and fourth ventricular index, and you look carefully to the sterna magna and the trabeculation in sterna magna. Mystical plane is essential. The BEMS is the most complex structure, the more difficult to visualize, the more difficult to assess. MRI, as Dr. Moza was saying, MRI is not mandatory. MRI is complementary to the neurosonography and can only be asked if the sonologist asks a question. But doing the MRI without neurosonography is not, in my view, in my book, is not a good practice, although it may be more helpful in cortical migration problems. Now, the last take-home message for me is the BEMS. The BEMS hold the key to diagnosis. If you can assess the vein by measurement, the size and the elevation, then you are probably making a very good assessment of the posterior fossa. And I thank you so much for the invitation.
Okay, great. Well, thank you so much, Dr. Badruddin, for this excellent talk on posterior fossa. I think we need to take a break for the prayer, but before that, I want to see if there's any questions for this talk. Is there any questions from people, the delegates? Okay, so rather than carrying on with the next speaker, I think we're going to stop for the prayer. So maybe about 15 minutes, and then we can continue with the program. Can I just double check the recording? How would the recording of the webinar be made accessible to the delegates? Would they send the link or?
Yeah, we will send them the link. It will be maybe in few days. They will receive the link.
Okay, fantastic. Okay, well, lovely. Thank you very much. And therefore we will meet back. I mean, it's 10 to 6. No, it's 10 to 6 now, correct? And therefore shall we come back at about 6 or 5 past 6?
Thank you very much. Thank you.
Great. Thanks so much.
Bye. You guys ready? Megha, are you ready with your presentation?
Yes. Shall I share my?
No, I'm going to. We'll wait for the boss's green signal.
Yeah.
We have a Spina Bifida Foundation in India.
Okay.
A lot of children are being helped, those born with neural tube defects. And I'm on that prevention committee.
When are you starting in utero?
In utero repair of spina bifida, it's still a big challenge because the acceptance of the disability, which we cannot quantify, is a problem.
What about terminations? Are they accepted in India for spina bifida?
Very much. More than 95% diagnosed in the first trimester. And before the report goes, she will be on the table.
Okay.
I think we can start the session.
Yeah. Okay. Welcome back to the meeting, and please post all your questions so that we can have a good discussion with the faculty. It's my pleasure to invite Dr. Megha Venkatraman, who is a senior consultant in fetal medicine in Cole Hospital. After passing, she's finished her MD from Mumbai University and moved to Oman in 1991. Then she's been working in the Ministry of Health, and also she worked with Professor Peter Sutil and did her advanced diploma in advanced obstetric ultrasound and fetal medicine by the Royal College of RCOG and RCR. That program is not existing anymore, but that is a beautiful program which was available at that time. She finished her membership from the UK and also member of the International Society of Ultrasound and ONG. She has been an instructor and trainer a number of fetal medicine courses, and also trained a number of doctors, including OMSP residents in Oman for the basic art of fetal ultrasound. And she's also been a guest speaker in many conferences in Oman. Dr. Megha will now talk to us about neural tube defects. Megha?
Yeah. Thank you, Dr. Suresh, and thank you, Dr. Musa, for having me. I seem to have been sandwiched between a lot of difficult but excellent talks, and I'm really glad that I'm talking on one of the easier topics, the neural tube defects. Neural tube defects are the second most common malformations which are seen in the fetus after cardiac anomalies. The prevalence is highly variable worldwide, and this is likely because of the differences in the genetic predisposition and the environmental factors. Not much is known about the etiology of neural tube defects. A lot of risk factors have been implicated, genetic as well as non-genetic environmental, and the list I have here would probably just a small of those which are seen. Depending on the time of embryogenesis, when the disruption takes place, the neural tube defects may be open neural tube defects, where you have absence of the epithelial covering, so that the neural tissue is exposed to the amniotic fluid, or you may have a closed neural tube defect, which occurs later on in embryogenesis, and there would be an epithelial covering in these cases. Now, it is not possible for me to talk about each one of these, so I'm only going to concentrate on the three most important ones: exencephaly, anencephaly sequence, the myelomeningocele, and encephalocele. Right. So exencephaly results when the cranial portion of the neural tube fails to close early on, around 18 days post gestation. The amniotic fluid is neurotoxic, and therefore the exposed neural tissue disintegrates, converting the exencephaly to anencephaly. The primary marker for acrania is absence of the skull bones, as we know, which should be ossified after 11 weeks. And therefore, anencephaly is always correctly diagnosed at 12 to 13 weeks. However, diagnosis or at least suspicion early on, or even around 10 plus weeks, is possible. There may be a smaller CRL than expected for the gestation, then you correctly know the dates. The fetal head may be small, or in the sagittal views, you may find a flat, irregular head with forward protrusion of the cerebrum. This is called the Elvis Presley profile. Or in the coronal views, you would have the cerebral hemispheres hanging on the sides, giving rise to a bilobed or a Mickey Mouse shaped head appearance. Now, as I said, amniotic fluid is neurotoxic, and there is gradual disorganization or disintegration of the embryonic brain, so that later on you would get a disorganized brain, which would be seen as an echogenic mass on scan. This is called the area cerebrovasculosa. The cranium above the orbital lines is absent, and therefore you would have what we commonly know as the frog eyes or the protruding eyes. In isolated cases, chromosomal anomalies are very rare, so we do not normally offer karyotyping. 50% of cases of encephaly may be associated with spina bifida. It is a uniformly lethal malformation, and therefore termination of pregnancy should be offered to this woman. However, when pregnancy continues, as it does in our country at times, routine prenatal care is important, because about 25 to 50% of the cases with anencephaly will develop polyhydramnios and is accompanied complications. Our aim is therefore vaginal delivery with LCS only when indicated for maternal reasons, as most of this anencephaly newborns die within 24 to 48 hours of birth. Coming to spina bifida, the open spina bifida or spina bifida apeta. This is a cleft in the vertebral column along with a skin defect, thus exposing the spinal cord and the meninges. It is due to failure of the spinal neural tube to close by day 28 of conception. Most often, it involves the lumbar and the sacral region in about 80% of the cases, but any segment of the spinal column may be affected. Ultrasound has largely replaced maternal serum alpha fetoprotein estimation in the prenatal diagnosis of spina bifidas. With high resolution ultrasound and in the hands of a very experienced sonographer, most cases of spina bifida can be picked up, and even in the first trimester, which will be covered later on. Spina bifida is divided into 3 types depending upon the contents that are herniated through the vertebral defect. In meningocele, you will only have herniation of the meninges with cerebrospinal fluid, while in a myelomeningocele, you have a vertebral defect with herniation of the neural elements, the nerve roots, meninges, and the CSF. Myeloschisis, on the other hand, is a vertebral defect without an obvious sac, which you have a flattened cord at the edge, which may be completely or partially covered by a thin membrane. So in ultrasound, in a meningocele, you will see a cystic protrusion through the vertebral defect, while in a myelomeningocele, you will have a myelomeningocele sac protruding through the defect. The echogenic lines that you see are the neural elements which are surrounded by the anechoic cerebrospinal fluid. Now, it is possible to determine the level of the defect by either counting down from the last ossified vertebrae. The faintly ossified vertebrae is S4, or counting down from the last thoracic vertebrae, the T12, which is the last vertebrae with a rib. And it would therefore be possible to determine the exact lesion. Or now on transverse view, in a normal transverse view of the spine, you see the body of the vertebrae and the 2 laminae which are converging together with an intact skin. While in a myelomeningocele, you could either see a V shape, displaying of the laminae or the vertebral arches, and you would either see a V-shaped vertebrae or a C-shaped vertebrae with protrusion of a myelomeningocele sac and the echogenic neural elements. The coronal view, in normal coronal views of the spine, you have the 2 laminae which are parallel to each other. While in spina bifida, you will have plane of the laminae, and the anechoic ovoid shaped structure that you see inside is the neural placode. You will also see the meningomyelocele sac on a coronal view, again with the anechoic ovoid neural placode in between. Myeloschisis, on the other hand, as I said earlier, is not accompanied by a sac. You have a defect in the vertebrae. The neural elements are within the spinal canal, but the defect may be covered by thin membrane. And alternately, in the transverse view, you see playing of the arches, but no sac. It can be sometimes difficult picking up spina bifida, especially if the fetus is in the breech position or the spine is posterior. But finally, we have some cranial signs which will alert us to the presence of spina bifida. And these, as we know, most commonly are the lemon sign and the banana sign. The lemon sign is because of scalloping of the frontal bones in the region of the coronal sutures. It is seen in about 50 to 90% of cases of spina bifida before 24 weeks. And it is due to the low hydrostatic pressure in the brain, secondary to continuous leakage of the cerebrospinal fluid through the open spinal defect. After 24 weeks, the lemon signs often disappears. It may be seen in only about 30% of the cases, and this is likely because of the ossification of the skull bones. Lemon sign, however, is not really diagnostic of spina bifida because it is seen in about 1% of the normal fetuses. And if you don't angulate your transducer properly, you may create a false lemon sign. Now, the banana sign is due to the herniation of the hindbrain through the foramen magnum, again because of the low hydrostatic pressure and the continuous drainage of the CSF through the open defect. So instead of a normal dumbbell-shaped cerebellum, you will have a crescentic-shaped elongated cerebellum, and you're not able to see the cisterna magna. There is obliteration of the cisterna magna. This banana sign again, which is also called because of the Arnold-Chiari malformation, is seen in most cases in before 24 weeks of gestation. After 24 weeks of gestation, this sign may not be seen. What you may then see is either absence of the cerebellum with complete obliteration of the cisterna magna. Ventriculomegaly is seen in about 70 to 90% of cases with spina bifida, and its prevalence increases with advancing age. And again, this is because of the obstruction and flow of the cerebrospinal fluid because of the Arnold-Chiari malformation. Microcephaly is seen in about 70% of the fetuses, and it is due to the chronic CSF loss through the spinal defect. The low hydrostatic pressure in the brain is not able to maintain the head growth. As we've seen earlier, it is diagnosed when the head circumference is smaller than 3 standard deviations below the mean for the gestational age. The head circumference to abdominal circumference ratio would be below the 3rd centile. And another indication is that you would see a sloping forehead on fetal profile. Spina bifidas are often associated with other anomalies, some of which can be picked up on scan, like agenesis of the corpus callosum, or even spinal anomalies like kyphosis, scoliosis, or abnormal angulation of the spine. A small percentage of fetuses with spina bifida have congenital talipes. And most of these develops after 20 weeks of gestation because of progressive deterioration of the motor function, secondary to exposure of the neural tissue to the neurotoxic amniotic fluid. So even if you don't see talipes earlier on in pregnancy, the baby may be born with talipes. So once spina bifida has been diagnosed, a detailed anatomical survey needs to be done to rule out any other anomalies. Fetal karyotyping should be offered when other anomalies are present, and also serial scans need to be done to monitor the progression of ventriculomegaly, any spinal deformities, or for the development of talipes. MRI may be indicated in certain cases where you need to delineate the cerebral parenchyma better. Now, when coming to parenteral counseling, apart from the diagnosis, the cause, the management, it is equally important to explain to them about the risks of neurological deficits that the child may have. And these include loss of sensation of the lower extremities, paralysis of the lower extremities, bladder bowel incontinence, learning disabilities, seizures, and sexual disorders, dysfunction later on in life. The controversy exists regarding the optimal mode of delivery. There's some who believe that spina bifida should be delivered by cesarean section. However, there is no clear evidence that analysis will improve the outcome in these children. Now, fetal surgery is now being offered in a number of centers around the world. The MOMS study, or the management of myelomeningocele study, which was carried out between 2003 and 2010 in Philadelphia, demonstrated that the surgery, when performed before 26 weeks of gestation, improved the prognosis. There was a decreased need for shunting. There was a reversal of the Arnold-Chiari malformation and better neurological function in the prenatal repair group as compared to the postnatal repair group. Of course, an hysterectomy had to be done for this, and that does carry maternal as well as fetal risks. The MOMS-2 study looked at the follow-up of these children who took part in the initial MOMS study. And this suggested that the benefits continued in the preschoolers and the schoolers. They had a better mobility, but there was no real difference in the cognitive function. Now, because of the success of this MOMS study, fetal surgery is therefore offered either by hysterectomy or fetoscopy. It's considered to be a treatment option in some cases of myelomeningocele. Now, encephalocele is herniation of the meninges and or the brain tissue through a skull defect. This defect occurs later on in embryogenesis. It is a post-neurulation defect because of failure of the surface ectoderm to separate from the neuroectoderm. It is therefore a closed neural tube defect, which is covered by a skin, either a partial or a complete skin thickness. The etiology, as with other neural tube defects, is multifactorial. The most cases of encephalocele are occipital. It's seen in about 85% of the cases. But you may have encephalocele at any other sides, including parietal, frontal, even the frontonasal, orbital, or nasal. Encephaloceles are divided into 3 types depending on what has herniated through the skull defect. In meningocele, you will only have herniation of the meninges with the cerebrospinal fluid, while in a meningoencephalocele, you have herniation of the brain. In an encephalocystomeningocele, you have herniation of the ventricular system along with the brain tissue. Encephaloceles, apart from ventriculomegaly and microcephaly, which are the direct effect of the herniation, are associated with anomalies in almost 23 to 40% of the cases. These may be CNS anomalies, spinal anomalies, or even extracranial anomalies, including trisomies. In fact, encephaloceles are a part of more than 30 genetic syndromes. On ultrasound, you will see a mass which is herniating through the cranial defect. It is possible to locate the cranial defect. There may or may not be distortion of the intracranial anatomy depending on what has herniated. And in a meningocele, you will see a cystic mass, while in a meningoencephalocele, you will also see echoes from the brain tissue. These are a few of the cases that we have seen in our clinic. This was an encephalocele, which was seen at 16 weeks. Most of the brain is extracranial with grossly distorted intracranial anatomy. And incidentally, this fetus also had a unilateral multicystic dysplastic kidney. This was another case, first seen at 25 weeks. That's the encephalocele, echoes from herniation of the brain matter. But what we also saw was gross ventriculomegaly with herniation of the ventricular system. At 35 weeks, the ventriculomegaly had increased grossly, and so had the herniation of the ventricles, which had compressed the cerebral tissue peripherally. The fetus also had an irregularity in the thoracic spine, which was diagnosed as a hemivertebrae after birth. A cesarean section was needed because of the large head size. The baby had repair of the encephalocele and a shunt placement later, but unfortunately had global developmental delay a year on. This was the case again with a large encephalocele, distortion of the intracranial anatomy, microcephaly because of the encephalocele. This bilateral echogenic enlarged kidney, polycystic kidneys, and also post-axial polydactyly of all the extremities. This was a case of Meckel-Gruber syndrome. So when an encephalocele is diagnosed, you need to do a detailed anatomical survey to rule out any other anomalies. Invasive testing needs to be offered as needed. The prognosis will depend upon the location of the encephalocele, the size, the content, and the presence or absence of any other cranial or extracranial anomalies. When large, termination of pregnancy can be offered in places where it is legal, and the mode of delivery has to be individualized. With a good prognosis, an LSCS may be done to avoid any brain trauma. Termination of pregnancy is not really an option we have in Oman. So we do individualize our delivery depending upon the degree of herniation. After the success of the MOM study, fetal surgery has been tried in encephaloceles in a small group where they found that there was improved neurological development and lesser incidence of microcephaly, but it is still not a standardized thing and it's still not accepted worldwide. A talk on neural tube defect cannot be complete without mentioning about folic acid supplementation. In 1991, the Medical Research Council vitamin study showed that daily supplementation with 4 milligram of folic acid 3 months before and continuing 3 months during the first few months of pregnancy prevented 71% of recurrences of neural tube defects. In other studies, randomized controlled trials, as well as observational studies have also shown that preconceptional folic acid in addition to folate in the diet can reduce the occurrence as well as the recurrence of neural tube defect. But it should be remembered that supplementation does not prevent all neural tube defects because the etiology is likely heterogeneous and depends a lot on genetic predisposition. Most organizations therefore suggest that all women who are planning pregnancy should take 0.4 milligram per day of folic acid. Those with previous history of neural tube defects should take a higher dose, about 4 milligram per day, and higher dose should also be recommended to those who are on any anti-seizure medicines, those who have any renal or liver diseases, sicklers, diabetics, and those with high BMIs. Parenting counseling is extremely important and difficult. A thorough knowledge of the etiology, the incidence, the history, complications, management, prognosis is needed. and therefore for NTDs, it is best done along with the obstetricians, neurologists, and the neurosurgeons. It's very important. I've had a patient, I've had a father who was extremely angry with his wife because a doctor had told them that the baby had a spina bifida because she had not taken folic acid during her first few months. Moms love to blame themselves for any problem with the fetuses, even if it's a minor problem or a normal variant. And I always like to tell them that whatever is wrong with the baby is not their fault. Thank you.
Thank you very much. That was really comprehensive overview of the different types of neural tube effects, very systematic approach. So thank you very much. I can't see any questions yet. And just for the interest of time, I think we're going to move with the next talk, which is my talk on the destructive brain lesions, which I think I'm just going to put up. Can you see my slides?
Yes, we can see your slide.
Okay, fantastic. Thank you. And let me just get the pointer as well. No, not the highlighter. Okay, fantastic. Thank you so much for inviting me to give talk on the CNS and anomalies due to destructive. Covers a number of topics. I'm going to start with intracranial hemorrhage because it's a topic that I think people sometimes struggle with counseling the patients, and it's something that we also have recently published a paper on, which I'm going to share with you some of the results, which I think hopefully will be very helpful to you when you counsel your next patient. So intracranial hemorrhage is relatively rare. It's about 1 in 10,000 pregnancies, and it's often, most of these cases are diagnosed later in the second half of pregnancy, so after your routine anomaly scan. If you look in the literature, you find that the mean gestational age at time of diagnosis is at 31 weeks, so it is in the third trimester. The terminology, it depends on the location of the bleeding or the hemorrhage, and you can see here on the figure on the right hand side, so subdural hemorrhage, for example, or it's intraventricular hemorrhage, or it is subarachnoid hemorrhage. But generally speaking, in fetal life, broadly speaking, intracranial hemorrhage could be intracerebral or extracerebral. The extracerebral is in subdural, and the intracerebral is either intraventricular or infratentorial. What do you see on ultrasound scan? What are the diagnostic features? We see the bleeding or the blood clots as echogenic substance. If it's, for example, in the lateral ventricle, is often separate from the choroid plexus. So you can see the blood clots. Sometimes you see it floating in the fluid in the lateral ventricle. You often, it can cause obstruction of the ventricular system, often at the level of the aqueduct, and therefore it's quite common finding to see associated ventriculomegaly, or this is in this case dilated third ventricle. You also see that the walls of the lateral ventricle here becomes echogenic. Sometimes you see maybe ependymal lesions or become nodular. Here you can see the blood clots, and you can see these blood clots in different views. So whether you see it in the axial view or the coronal view or the parasagittal view. if you see that this bleeding extended beyond the ventricle, so like here is outside the ventricle, and you see here the moss eaten appearance of the parenchyma, so the echogenic irregular lines. Here you see the blood clots, and the blood clots, the appearance would vary according to when you scan the patient. So if it's a fresh bleeding, you see it echogenic. If it is a week or two later, you would see the inside of the blood clots becomes a bit echolucent with an echogenic border. And sometimes you see the choroid plexus almost being compressed by the ventriculomegaly. As I mentioned, the sonographic findings will depend at what stage. Is it a fresh bleed or is it a bleed that happened, 2 or 3 weeks ago? So as I mentioned, initially you would see this echogenic bleeding fresh, but as time goes, you can see here, this is the irregular echogenic borders of the ventricle, the lateral ventricle. You see the ventriculomegaly. You see here the porencephalic cyst, which is because of the ischemia. As I mentioned earlier, there may be hyperechogenic nodular ependyma. And as I mentioned, or the porencephalic cyst is because of the secondary to the bleeding or the ischemia. And in very, very severe cases, you might even see hydrancephaly, which is loss. You don't see any normal brain. And the differential diagnosis would be severe hydrocephalus, and it's a lethal condition. So again, just to show appearance, so you see the ventricular hemorrhage, and you can see the severe bilateral ventriculomegaly. And in fact, if any case of ventriculomegaly, you really need to look for any evidence of intracranial bleeding and comment the fact that whether you have seen any features or signs of intracranial bleeding or not. What are the causes of fetal intracranial hemorrhage? Well, you can group them into maternal factors or fetal factors, and that's really emphasize the importance of taking a history from the mother with a medical history. So does she have ITP, for example? Does she have any coagulation disorders? Has there been any history of infections? Is pregnancy complicated? Has she got preeclampsia or abruption? Is she taking any medication like warfarin? Is she a drug user, particularly cocaine? For the fetal factors, certainly you see a list, and nowadays with you see these cases, well, most of the cases that nowadays we see is a twin-to-twin transfusion syndrome or complication of following single intrauterine demise in monochorionic twins. Also, you would see, for example, the fetal alloimmune thrombocytopenia or SNAT. And it's really important not to miss this diagnosis because it has very high risk of recurrence. And also because now we know that we could treat it with the immunoglobulins. But as I circled here, this unclear or no cause found, because the truth is in the majority of the cases of fetal intracranial hemorrhage, we don't actually find a cause. This is a area we published recently on the peri-term outcomes of fetal intracranial. And the reason we did that is that these are relatively rare conditions. So you see a case every few months. When you see this case, people often struggle to counsel the parents or answer the questions. And therefore, we really wanted to have maybe more robust data to be able to help us counseling the parents. And in fact, if you look at this, the outcomes, we looked at a long list of outcomes, but I'm going to share with you some of the key ones. So for example, if you look at the risk of intrauterine deaths in cases with a prenatal diagnosis of intracranial hemorrhage was about 10%. Neonatal death was about 7%. About 1 in 5 of these pregnancies or the parents decided to have termination of pregnancy. What about the long-term outcome, which is really important because for parents who are continuing the pregnancy, they tend to ask this question: what is the chance of neurodevelopmental delay or cerebral palsy? What is the chance of the baby needing postnatal surgery or shunt? What is the chance of my baby being normal? And therefore, I think these figures might be useful when you counsel these parents. So about a third of them, 28%, will need surgery or shunt postnatally. About a third have cerebral palsy. About 15 to 20% have mild developmental delay. About a third have severe neurodevelopmental delay. And the normal outcome is about half of these cases. But things are not that straightforward. And one size doesn't fit all, because actually there are different types of intraventricular hemorrhage or different grades. So there are 4 grades. Grade 1, when you have hemorrhage that's confined to the germinal matrix, not the lining of the ventricles. Grade 2, when you have this bleeding that's have extended to less than 50% of the volume of the ventricular system. Grade 3, with the volume of bleeding is more than 50%, or there is ventriculomegaly. And grade 4, which is the most severe, when there is extension of the bleeding in the brain parenchyma. It's important to know that the majority of the cases, nearly 90% of the prenatally diagnosed cases of intraventricular hemorrhage belong to grade 3 and 4, so they're more severe. And that might be because actually often we miss the earlier grades. We definitely miss most of the grade 1. And again, grade 2, because as I mentioned, most of these cases happens in the third trimester, where maybe we don't do routine after all the routine anomaly. The appearance ultrasound scans, you see here, this is grade 1. So you can see that just the bleeding, so the germinal matrix bleeding, but the ventricles look normal and the rest of the brain look normal. This can be easily missed. Grade 2, and you can see this echogenic lesion or echogenic mass in the lateral ventricle, but it's less than 50%. Here, grade 3, you see this is echogenic, or the bleeding is more than 50% of the ventricle, and also there is a ventricular dilatation. In grade 4, when you see that this bleeding extended into the brain parenchyma. And therefore, the data that I showed you earlier was about intracranial hemorrhage. And as I mentioned, the intracranial hemorrhage is classified according to the location of the bleeding. So what about intraventricular hemorrhage, which is the most commonly diagnosed prenatally? So you see here, again, if I look at these 4 outcomes, with the perinatal death with about 10% or about 5% risk of intrauterine demise, 7% risk of neonatal death, and about 20 to 25%, so about 1 in 4 of these parents decided to have termination. But I mentioned too, the intraventricular hemorrhage has different grades, and therefore we need to be a little bit more sophisticated or more specific in our counseling to the parents. Not great. So in this meta-analysis, we lumped grade 1 and 2 together and grade 3 and 4 together, because that's what was reported in most of the studies. So you see grade 1 and 2, which is mild, which represent only about less than 15% of the prenatally diagnosed intraventricular hemorrhage. You see that the risk of intrauterine demise is about 13%, 0 risk of neonatal death, but still there was significant or relatively high number of terminations. Grades 3 and 4, 7% risk of intrauterine demise, 6% of neonatal death, and about a third had termination. But this is probably the most important slide in this meta-analysis, the fact that the long-term outcome is very different from when it's grade 3 to 4 from grade 1 to 2. So for example, you see the cerebral palsy was about 0, almost very, very, very low risk if it's grade 1 and 2, while it was about 30% in grades 3 and 4, about a third of cerebral palsy. And if you look here for the severe neurodevelopmental delay, again, about 0 in grade 1 to 2, while it's about 46%, nearly half. And the normal outcome was about 100% in grade 1 and 2 compared to about 40% in grade 4. And therefore, it's really important that we as fetal medicine specialists try to be a bit more specific in our counseling based on our detailed ultrasound assessment and knowledge. The most important differential brain or intracranial hemorrhage is tumors. You can see here in these 2 clips, the one on the right-hand side, this is intraventricular hemorrhage, while on the left side is the brain teratoma. And you can see it's heterogeneous, it's echogenic, it tends to be vascular, and when it is, and a lot of these tumors tend to continue to grow quite at a fast pace. very important, and probably the most important tool, ultrasound tool that you use to help you with the differential diagnosis is a color Doppler, because when you put the color Doppler on a bleed or hemorrhage, there's no vascularity, while actually in a tumor is more likely to see vascularity. Additional investigations which you perform when you have a case where you think it might be intracranial or intraventricular hemorrhage. Well, of course, you need to do detailed neurosonography, because you're also looking for other features or consequences of this bleeding, like the porencephalic cyst, for example. We could also do fetal brain MRI, and the added value of the MRI above and beyond your ultrasound scan depends very much on the level of the detailed neurosonography that you could offer or your center can offer. We need to take a maternal blood sample from the mother to do a torch to look for fetal infections, because one of the causes of bleeding. The genetic testing, we tend to offer it routinely, and one of the probably the famous genes or gene mutations that tend to be associated with intracranial hemorrhage is a COL4A1, which is a collagen or lead to collagen disorder, and therefore increase your risk or susceptibility to bleeding. And of course, we must not forget the maternal blood for antibodies for then neonatal and immune thrombocytopenia, because as I mentioned, it tends to have high risk of recurrence. The bleeding tend to be more severe, and it's also nowadays we do have option or potential treatment in the form of the IV immunoglobulin. But it's also important that we need to know, and also we need to mention to the parents that actually there is a high chance that even after you do all this additional investigation, you might not be able to identify the cause of the bleeding. And in fact, if you look at the literature, a possible etiology was only identified or reported in about 20 to 45%. So less than half of the cases we could identify etiology even after the investigations. Moving on to porencephaly, and I did mention it to you briefly, and I showed you an example in association with intraventricular bleeding. They tend to be maybe one or even multiple cysts. They tend to, in the brain, to communicate with the ventricular system or with the subarachnoid space, or sometimes with both. They are different types, or two types of porencephaly. Type 1, they tend to be unilateral, often related to hemorrhage or ischemia. So for example, there is an arterial stroke or venous stroke. Type 2, which tend to be bilateral, which is less common, bilateral and due to neural migration disruption. And this is a case when you can see here sort of the cyst communicates with the ventricle. And in fact, if you look carefully, you can see there is evidence of bleeding. So there was an old bleed here, and you can see the debris or the debris in the ventricles here in the lateral ventricle lying on the walls. And in fact, if you shake it, it's almost, you see it almost floating in the fluid in the ventricles or in the CSF. Move on to schizencephaly, and schizencephaly, again, it could be unilateral or bilateral, and it's just a cleft, it's lined by the gray matter. It connects the ventricular system with the subarachnoid space. That's a characteristic feature. And majority of the cases, 2/3 of the cases, affects the parietal lobe. And again, more than half of them, they are associated brain abnormalities, such as agenesis of corpus callosum or septic optic dysplasia or severe ventriculomegaly. And again, schizencephaly can occur following ventricular or intracranial hemorrhage. It could be with fetal infections, it could be with ischemia or stroke. The hydranencephaly, which is probably the most severe, when actually you see almost just the head is full of fluid, you don't identify any normal brain tissue. If it's related to hemorrhage, you might see hemorrhagic debris here. You see the fenestrated falx cerebri. It's often because of ischemia. So for example, if it's affecting the anterior or the middle artery, in this case, you find the cerebellum is spared. In this case, you can see the normal cerebellum, and it tends to be lethal. And the main differential diagnosis is severe hydrocephaly. Moving on to the fetal brain tumors, they tend to be very rare. The most common, more than half of them in the prenatal or the fetal life, they tend to be teratomas, followed by gliomas, the choroid plexus papilloma, and the craniopharyngiomas. The incidence of all fetal tumors is about 2 to 15 per 100,000 live births, but the brain tumors is even more rare. They constitute only about 0.5 to 2% of all pediatric tumors, so they're very, very rare. The prognosis in the majority of the cases tend to be poor with high risk of demise, be either cancer, malignant or benign, and sometimes even with doing an MRI, or is often you can't really reach the final diagnosis without the additional help of histopathology or molecular analysis or even complex genetic testing. As I mentioned, the commonest brain tumor that we see in fetal life is teratomas, followed by gliomas. And as I mentioned again, just to reiterate, sometimes we might not be able to reach the definitive diagnosis in fetal life. The prognosis is poor, survival rate is only 30%. The recurrence risk is not increased unless there is a genetic component to it, and it's often associated with other abnormalities. There's another case that we saw a few years ago, diagnosed at 36 weeks, but you see late in pregnancy, late in the third trimester, and you see again this echogenic lesion, and it was near the base of the skull related to this sphenoid bone, and it's got sort of a capsule there. There's a degree of vascularity. You see the MRI images here. So the base of the brain, you see there's a nice capsule there. You see here in different views or different planes. And we not the exact diagnosis or nature of this tumor during the fetal life. Unfortunately, this woman had termination of pregnancy because of the poor prognosis, and the histopathology was meningioma. And the differential diagnosis will be based on the location, but again, even when you look at the location, for each location, there are a number of possibilities, and therefore it's really difficult to be able to reach the exact nature of the fetal brain tumor during the prenatal life. It's important to note that some of these tumors can have or can be linked to genetic syndromes, and therefore, again, that's often postnatally, not prenatally, but whenever you find the final diagnosis, don't forget to liaise with your genetic colleague or your genetic specialist to look for potential genetic syndromes. Moving on to the last part of infections, and it's often, in fact, the finding of an abnormality on the ultrasound scan that will perform testing and reach the diagnosis of fetal infection. And a very important group of anomalies, congenital infections, is affecting the brain. And in fact, also the brain abnormalities, they are very important factors for the outcome of the baby. So for example, in the case of congenital CMV infection, having a mild unilateral ventriculomegaly have very different prognosis to having severe cortical abnormalities and severe ventriculomegaly. So the things that if you see in the brain, number one, should trigger you to do TORCH screen and diagnose or look for fetal infections, number one. But also, if you have a diagnosis of maternal infection, these are things that you need to look carefully and to do detailed neurosonography looking for these abnormalities. And things like ventriculomegaly, things like calcification, the intraventricular adhesions or synechia, they can affect the cerebellum, can cause small cerebellum, cerebellar hypoplasia, or cerebellar abnormalities, or cerebellar bleeding. They can cause, of course, intracranial bleeding, like I mentioned earlier, Vermian abnormalities, and the periventricular cyst, which covered in his talk, malformation of cortical abnormalities like lissencephaly, like polymicrogyria, like the schizencephaly that I mentioned earlier, and of course, ultimately microcephaly, which is often because of the smaller brain underneath. I'm going to finish my talk with showing you this case, which is sort of a typical really presentation of congenital infection, because most countries do not routinely screen for fetal infection or congenital, or could potentially cause congenital infection like CMV, for example, or toxoplasma or Zika. So this lady that was old, had a previous completely healthy, uncomplicated pregnancy. Following her anomaly scan at 20 weeks, the baby was small. So you see the head circumference, the femur, the abdomen circumference, and even the cerebellum was also small. The Dopplers, and you find all the Dopplers were within normal range. You do obviously look at your detailed anomaly scan, and you find a multitude of abnormalities. I think this baby had infection. In this case, was V. So you see the hepatomegaly, a degree of myelitis, there's echogenic bowel, there's oligohydramnios. Regarding the brain, small cerebellum, as I mentioned earlier, the interventricular adhesions, the periventricular echogenicity, or the halo sign. And in this case, obviously, amniocentesis, you look for the CMV PCR is positive, and in view of the poor prognosis, at least in the UK, the parents opt for termination of the pregnancy in view of the poor prognosis. Obviously, fetal infection is an area where there has been some development. I did not cover it in this talk because of the time, but the potential use as a treatment to reduce the risk of transmission following diagnosis of maternal primary CMV infection early in pregnancy. So that's potential. And also the role of valacyclovir in treating fetus with mild symptoms to reduce the risk of symptomatic infection at birth. I'm gonna stop here, and I'm gonna be happy to take any questions. Okay, so unfortunately, Professor Suresh had to go because he had another meeting. We're running a bit late. I'm gonna have a look in there if there's any questions. Okay, so Dr. Solmas, could you please comment on any lower gestational age limit when we usually see brain hemorrhage? I don't think that there is any cutoff below which that you will not be able to see brain hemorrhage. But as I mentioned, the majority of the cases are in the second half of the pregnancy following your anomaly scan. The mean gestation age is about 31 weeks. But there is no reason to say that it can't happen earlier. Certainly, I have seen hemorrhage or bleeding at 20-week anomaly scan. So certainly, you could also see it at earlier gestation. Okay, any other questions? I'm just looking carefully. There's some question, Dr. Mose. Yeah, can get recording of this webinar. I think we did mention earlier that you will have the recording. What advice to be able to diagnose hemorrhage during a cross scan? To diagnose hemorrhage. Well, as I mentioned, when you actually have your axial view and the subaxial view, you're looking for this echogenic mass or echogenic material in the ventricle that's separate from the choroid plexus, or you might see the consequences of the bleeding, like porencephaly or schizencephaly, or even in severe cases, hydrancephaly. And that's because either there's been severe bleeding or massive bleeding, or because actually there was a ischemia secondary to arterial stroke, for example. When to intervene, time and mode of delivery? Very good question. And I initially had it in my slides, and because of the time and because we're running very late, I removed it. So the mode of delivery and when would you deliver? And in my talk, I covered various topics of destructive lesions. But if you, for example, focus on the intracranial hemorrhage, I think it depends on the severity of the hemorrhage, but to be on the safe side, I think it's better to be delivered in a unit where there's obviously access to neonatal facilities or neonatal intensive care unit in case that's needed. So that's when to deliver. The gestation age of delivery, I don't think that is an indication to deliver premature, because prematurity per se have obviously increased risk of adverse neonatal outcomes and long-term outcomes. And how would you deliver? I don't think, unless, for example, the baby have NAT, just having an intracranial hemorrhage, particularly if it's an old bleed, I don't think that's per se will be an indication for cesarean section. But if you have a NAT case, I think it's reasonable to consider the option of cesarean section. Okay, I hope that I answer your question then.
Yeah, I have a question. It's now regarding the congenital cytomegalovirus and the option of giving acyclovir. When you have sonographic findings like ventriculomegaly or periventricular calcification, do you think starting acyclovir will improve the fetal outcome in such cases?
A very good question. And despite the fact that evidence is limited, there have been there are two indications for fetal for valacyclovir. Is it one supported by a randomized control trial, single center from Israel, but still randomized control trial. So very good evidence to say if the mother had primary infection, first trimester, give valacyclovir, reduces the risk of transplacental transmission by 70%. The other one, which is what you're asking about, is that you've already have a diagnosis of congenital CMV infection. You've done your amniocentesis, the baby is amniotic fluid is positive for CMV, and then you are considering giving the valacyclovir to reduce the risk of being symptomatic at birth. And the evidence we have was from the French study where they treated the mild to moderate cases. So for example, if you have just calcification, yes, I think you should consider it. If you have mild ventriculomegaly, yes, you should consider it. If you have just intraventricular adhesions, yes. I think the problem when you have severe ventriculomegaly or already severe cortical abnormalities, I don't know whether you already missed the boat and the baby is going to be already have guarded prognosis regardless whether you give valacyclovir or not. However, I had this situation with two patients where they were committed to pregnancy. And therefore, it's very relevant to you, Moza, because you work in a country where maybe termination of the pregnancy is not an option, or the parents will not consider it. And therefore, in a pregnancy where the mother is committed to the pregnancy or termination is not an option, is it reasonable to give valacyclovir? I think so. If you counsel the parents, sort of in details and say, look, there's no evidence. I think we have done that in a couple of cases. Still, the prognosis was awful. Still, the baby didn't do well. Still, the baby had symptoms. One of them died. But, and while we're doing this, because these cases are, your management is not supported by strong evidence. And therefore, you need to be careful. But we actually had this discussion. Are we converting a pregnancy that would have ended in intrauterine demise or neonatal death because it's a severe infection to a live baby with very poor prognosis? We had the discussion, but at the end of the day, in the UK, we obviously have to respect parents' wishes. And when we discussed it, from my experience, often parents want to have the treatment because they're just really desperate to have anything to do to help the baby.
Yeah, actually, we had the same discussion with the neonatologist, and they had the same point that if you start acyclovir, what you are aiming? Are you aiming to prevent the intrauterine fetal death or improving the outcome? And in our situation, actually, where the termination of pregnancy is not an option, you have to explore all the options just for improving the outcome.
Yeah, I agree with you. Okay, I'm conscious of the time. I think there's one last question that we can do it before the last talk. So that's from Fozia Sajid. If TORCH is positive for any maternal infection or genetic test is positive, what next step should be? And I think you're asking this question in the context of intracranial hemorrhage. Well, of course, the prognosis and the management would depend on the underlying cause. So, for example, if the TORCH is positive for CMV, in this case, you will treat as if it's a congenital CMV infection. So still, if let's say the mother is positive for the CMV, there is evidence that she might have seroconverted during the pregnancy, and you're seeing intracranial hemorrhage, I would still probably want to do amniocentesis to see whether there's congenital CMV infection or not, because it may be actually maybe two pathologies happening at the same time, particularly if you're considering giving treatment like valacyclovir. For genetic tests, I've seen a number of intracranial hemorrhage. We've done the genetic testing. I've never come across this called genetic diagnosis, but it's reported in the literature. But of course, that the management will be depends on the genetic diagnosis. And if already there is poor prognosis, if you work in a country where there is that the termination of the pregnancy is a legal option, I would offer it, particularly if it's severe hemorrhage or there is a considerable risk of long-term neurodevelopmental impairment. But I work in the UK and that's a legal option late in pregnancy. Okay, fine. I think we need to move on. So the final talk of this webinar, and it's my real pleasure to introduce a friend who I worked with at King's College in London when she was doing her fellowship. And so a very important talk about obviously first trimester. So Dr. Solma Asbury is a fetal medicine expert. She's after receiving her MD from the Tehran University of Medical Sciences, she completed her clinical specialty training in obstetrics and gynecology at the Shahid Behshati University of Medical Sciences in Tehran. And afterwards, she got subspecialty diploma in fetal medicine from the Fetal Medicine Foundation in London in 2009. She published numerous books and research and review articles in peer-reviewed international and domestic journals with over 130 citations. She's the director of the International Affairs in Iranian Association of Gynecologists and Obstetricians. She's also a member of several national committees, including Ultrasound Committee of the National Iranian Association of Gynecologists and Obstetricians, Medical Disciplinary Committee of Medical Council of Islamic Republic of Iran, the Guideline Committee for Endocrinologic Disorders in Pregnancy, and Committee of Screening for Down Syndrome. And she won the National Association of Iranian Gynecologists and Obstetricians Exemplary Practice Award in 2016 and has been a virtual mentor of his work since 2019. So a fantastic career so far, and I'm sure that you will continue to achieve more. And her talk is on CNS anomalies, appearance in the first trimester scan. Thank you so much.
Thank you very much, Esma, for the very nice introduction. Actually, I have just sent the recording of my talk because of a little bit unstable internet connection, so I would ask it to be played. Thank you.
Zakia, if you please share the voice as well.
So when you share the screen, you need to have there is an option where you share the sound as well. We can't hear. I think you need to when you share the video, you need to also share the sound. Okay.
If
someone
you think it's not, I think I sent the complete video. Just actually, I checked with the with Musa, and nobody told me that the video doesn't have the sound. So if it does, that's okay. If not, I can. If you can hear me well, I can present my talk live.
Yeah, I think Solma, you can go off it with your presentation. It was there. We checked actually previously. I don't know what is the problem with Zakia. Zakia, you can stop sharing, and Dr. Solma, she will start her presentation.
Yes,
Did the recording, when you were playing the recording, did it have the sound?
Yes, doctor, it was working well. I don't know what is happening now.
Just because, you know, my internet connection might not be stable, so I'm not quite sure if you can hear all of it well. So that's why I sent the recording.
Zakia, if you don't mind, stop sharing, and Dr. Salma will present physically. Dr. Salma, you can go ahead with your presentation.
Okay. All right. Okay. Hello, everyone, and thank you very much, Dr. Musa, for your nice invitation and giving me the opportunity to take part in this prestigious webinar, many speakers of which are professors and experts in the field. So you just mentioned in your talk the ESWOC practice guidelines about neurosonography part 1 and part 2. I just, for the interest of times, I leave those slides. So also the importance and the prevalence of neural tube defects has already been discussed. So I just go ahead and I would like to mention that the fetal neurosonography in the first trimester is partly easier compared to later on in pregnancy because the bones of the skull are thin and the brain may be evaluated from almost all angles. The choice of optimal transducer and operation and the frequency.
If you share your slide presentation.
Okay, I have, can't you see my slides?
No, just show the slide.
Slideshow, please take it to the slideshow mode. We can see your entire presentation.
You see, I have a problem with my Zoom. When I go to slideshow, I can't change them. I don't know what's the problem. That's why I don't go to slideshow.
It's fine, you can go ahead.
If that's okay with you, yeah. Thank you. So the choice of the transducer and the frequency depends on maternal habitus, fetal position, gestational age, and the approach used. So depending on the situation, both 3 to 5 megahertz and 4 to 8 megahertz trans-abdominal or transvaginal probes can be used. So obviously, in order to see the brain well, we need to optimize our image by reducing depth, adjusting focal zone, narrow sector width, magnifying by zoom box, adjust dynamic range, use compound imaging and harmonic imaging, and also adjust speckle reduction. 3D helps in neurosonography, both TUI by providing us with multiple slides, and also VCI by providing us with thicker slices of fetal brain, which improves the visualization. So this is also the same slide that Dr. Musa showed from ESWOC guidelines. So you can see the axial planes, the famous transventricular plane. You can see choroid plexuses and the anterior horns of the future lateral ventricles, let's say. And this is a lower down slice. You can see the aqueduct, which is a very prominent structure at this age of the pregnancy. You can see the tectum around the aqueduct, and this is going to be the future cavum septum pellucidum. And also in mid-sagittal views and coronal views, you can see different elements. This is a very nice paper by Professor Volpi et al. Published in UOG 2020, and it has very nice comparison between ultrasound images, axial and coronal views with counterparts, with histological counterparts. which is very useful in understanding, I would say, rather complicated anatomy of fetal brain at this stage of the pregnancy. So as you can see, if you go further down from transventricular plane, you reach this plane where you see the anterior part of the choroid plexuses. You can see thalami. This is a translucent area, which is basically cavum, velum, interpositrum, the third ventricle, aqueduct, and also the tectum. A very informative section I would mention later on in diagnosing different abnormalities of posterior fossa. And this is the coronal view and the histologic counterpart, also very useful in identifying the different anatomical structures. So the new practice guidelines for first trimester of ISWOC are gonna be online, accessible through the website very soon. And according to that new practice guideline, which will replace the practice guideline of 2013, which is still on the website, 4 axial sections of first trimester fetal brain are recommended to be evaluated. So the first one is transventricular. As you can see, the choroid plexuses, the famous butterfly shape, which we used to examine from a long time ago. The irregularity in the posterior part of the choroid plexus of fetal brain at the stage of the pregnancy is a normal finding. You can go a little bit down. You can see a little bit of the thalami and the cavum, velum, interpositrum here. Then further down, you see the section that I already mentioned, the beginning of formation of cavum, septum, pellucidum, the thalami, more or less from a section from the thickest part, the aqueduct, the tectum, and the fourth ventricle. And this is the plane where we can assess the beginning of the signs of spina bifida. And this is again lower down. We can see the midbrain, the fourth ventricle, the choroid plexus of the fourth ventricle, and the Blake pouch cyst, which will form the future cisterna magna. This is the same 4 sections with a transabdominal view. In some areas of the world, especially in Middle East, where I practice, women are not very willing to have a transvaginal scan. This doesn't mean that we can't or we shouldn't look at different brain structures at the stage of the pregnancy. So as you can see, even with the transabdominal approach, we can see quite numerous bits of fetal brain anatomy at this age. This is a TUI using 3D ultrasonography, providing us with more slices of the fetal brain. And this is the mid-sagittal view, where we can see and measure intracranial translucency. As you can see, there are 3 prominent translucent areas at the mid-sagittal view, the same image that we measure nuchal translucency and we assess the nasal bone. This is, again, some correlation of the same mid-sagittal view with different anatomical structures. I would just like to mention that apart from intracranial translucency, measuring brain stem to occipital bone distance is also a helpful and sensitive marker in that screening and diagnosing spina bifida at this age of the pregnancy. A schematic presentation of the same anatomical structures, I took it from Fred's talk on YouTube. Again, a nice depiction of these 3 translucent areas. I just would like to, it is in the beginning of introduction of intracranial translucency, at least to me, it looked rather complicated, where to measure, which is intracranial translucency, which is what. But, if you take this approach into mind, that there are 3 translucent areas at the mid-sagittal view of fetal brain at the same plane that you measure nuchal translucency, little by little you train your eyes and you just get yourself familiarized with this finding, and it's important to see all three. This is sort of the same kind of screening that we have learned all over our career. So it's a good practice. It's an easy practice to pay attention to the three translucent areas decreasing in size from up to bottom towards the occipital bone. So let's now look at some abnormalities. Anencephaly, which is very easy to diagnose at this age of the pregnancy. The previous speakers have discussed it in detail, so I just go ahead, and this is holoprosencephaly. A lobal variant, you cannot see any bit of faults. This is from Professor Shaoi's paper. The area of choroid plexus at first trimester usually occupies about 50% of lateral ventricle. If it is more than this ratio, it is called so-called dry brain. So the cerebrospinal fluid is decreased, and this can be a sign of spina bifida because there's a defect in the spine which might cause leaking of the fluid and causes this dried brain appearance. This is a slide from Professor Marr's talk. As you can see, the dried brain in 4 axial section of fetal head, but this is not enough to diagnose spina bifida, and it is good practice to look at the spine and, if possible, to locate the place of the defect. In 2011, Professor Marr actually defined this sign of measuring the distance between aqueduct in axial plane to occipital bone and called it aqueduct to occipital bone measurement. It is the same sign that Fred basically described in 2019 as the crash sign. Both are more or less the same sign. So a sign for a screening and perhaps diagnosing spina bifida in first trimester of the pregnancy. As you can see, in the axial plane of fetal midbrain and tectum and aqueduct, this is the normal brain, you can see some space behind the tectum, between the occipital bone and the tectum, which makes the future cisterna magna. But here, in a case of spina bifida, you cannot see any measurable distance between these two anatomical structures. Fred called this sign crash sign. This is a case of ventriculomegaly. So as you can see, choroid plexus comprises less than 50% of the lateral ventricle. So this is a probable case of ventriculomegaly, needs proper chromosomal evaluation. And it's also good practice to look at any spaces if you cannot see or faintly see choroid plexus, but you can see the lateral ventricle filled with cerebrospinal fluid. Again, a sign of first trimester ventriculomegaly. This is a case of cystic lesion in the posterior fossa and protruding part from the back part of the skull bone, so encephalocele, and polycystic kidneys, so a case of Meckel-Gruber syndrome diagnosed in the first trimester of pregnancy. This is a different case. So if you can look at this mid-sagittal view of fetal head, you can see the 3 translucent areas, but they are not basically decreasing in size. So the middle area is enlarged. And when you see at the axial views, you can also see that the 4th ventricle is enlarged. So we brought back the patient at 16 weeks. So the cystic area in the posterior fossa and the asymmetric appearance of cerebellar hemisphere, so-called telephone receiver sign. And this was a face syndrome. We did an amniocentesis, and CGHRA analysis came back to be normal. And I'd like to thank you very much for your attention.
Okay, well, that's great. Thank you so much, And apologies for the people attending the webinar for the technical issues, but I think you managed it really well and being able to present it live and with no sort of network problem. So that's great. Thank you very much. Okay,
Thank you.
so I think any questions or comments from the delegates? I'm just looking at the chat function and the Q's and A's, or from anybody from any of the earlier talks. It seems that we are running really late, so I suspect people it's a Saturday, so we want to go. So unless there are any questions or comments, I'm happy to sort of close the webinar and just maybe reiterate again, I think a common question, how people would access a recording, Moza.
Yeah, the record will be shared with all delegates, and really, I think we all enjoyed all the talks. It was excellent talks from all the speakers. Myself, I have refreshed all my knowledge regarding the CNS, and I think it is very important to have such CME activities to improve our knowledge and information. I didn't expect actually to have 77. The registration was 190, but 77 who could attend, especially during the weekend. So I'm really thankful to all those who attended, and I'm grateful to all the speakers. Despite their busy schedule, they could join us and they gave us great talks in different topics. So thank you very much. And I hope inshallah we'll again have another meetings in different subjects. So thank you again.
That's great. Well, thank you so much. And thank you for inviting me to this webinar and inviting me to coordinate it with Professor Suresh, and just apologize on his behalf he had to go to because he has another board meeting. But it's been great, fantastic talks, great speakers, and really good delegates to stay that late on a Saturday. So thank you so much, and I hopefully look forward to seeing you soon. Take
Thank
care.
you. Thank you.
You're
all.
welcome.
Bye.
Bye-bye, guys.
Bye. Bye.